I would like to welcome you to Learning Session 1 of the Integrated Communities Care Management Learning Collaborative. My name is Nancy Abernathy. I'm a clinical social worker and one of the facilitators working with communities participating in this work. Together we aim to improve care, reduce costs, and improve the care experience for people with complex needs. Before I start, I have a few notes and housekeeping details. Restrooms are located outside to the left. You received a binder this morning. There is some confusion maybe about where the agenda for today is. If you look at your binder overview in the very first page, you will see tab 6, Learning Session 1, and there's everything you'll need for today. Little hard to find, but if you go to that now, that will tell you what we're planning to do today. Okay. I want to begin by thanking each of you for your willingness to join us in this very rewarding and very challenging work. We have teams from 4 communities here with us today. I'd like to introduce each team and ask you just to please stand so we can all begin to recognize each other as partners in this endeavor. So will the Middlebury team please stand up? Go Middlebury. Yeah. St. Albans. Welcome. Morrisville. And Central Vermont. Thank you. This is a wonderful turnout. And clearly, there is a lot of talent and experience in this room. The reason learning collaboratives have been successful in Vermont is because of the magic that happens when we get everyone together in the same room to talk in detail about this work. In a learning collaborative, we learn as much from what does not work as we learn from what does. In fact, I think we learn even more from what doesn't work. And when we share the things that have not worked, it helps others avoid these same mistakes. So we're not all going down the same dead-end paths, having to turn around and head in a different direction. This shared learning allows for what we call rapid cycle improvement. In short, we learn faster and we improve faster. As you know, you are the second cohort of communities participating in the Integrated Communities Care Management Collaborative. Teams from St. Johnsbury, Burlington, and Rutland have already started this journey. And thanks to them, we know more about how to do this work than we did a year ago. And remember, what we're asking you to do is something new. We're asking you to work across organizations to share the care, which is really a new way of thinking about the work, rather than this is my job, this is what my agency does. His job is a little different, and they do that over there. We're asking you to all work together. We know a bit more about how to engage patients. We know how to identify a lead care coordinator. And we have some good ideas about what information we want to see on our shared care plans. And there is much we are still learning. We struggle with how to best share information in real time with all care team members. We struggle with how to find sufficient time to do this complex work. We know there is a need to offer training for frontline staff in community agencies who work with individuals receiving integrated care management services. But let me tell you just one example from the Burlington area of what can happen when we get it right. In November of 2014, a patient I will call Brian was referred for care management by his PCP. His medical challenges included alcoholism, depression, anxiety, suicidal ideation, hypertension, hyperlipidemia, memory loss, amnesia, Tourette's syndrome, and cannabis abuse. His life was further complicated by financial instability, poor emotional regulation, housing instability, frequent emergency department visits, poor connection with a medical home, and little interest in follow-through with treatment plans, frequent no-shows for medical appointments, and significant neurological concerns. Maybe you can think of some similar individuals who you work with. By August 2015, last month, Brian has a lead care coordinator. Brian and his care team meet regularly to prioritize and address areas of instability, and he has not missed a single meeting. His finances have stabilized, and a relative is helping manage bills. He is motivated to quit smoking. He uses effective coping strategies to handle life stressors. His medications are stable. His housing is stable with assistance from SASH, weekly housekeeping, and assistance from CVAA. Primary care is in place. Specialty appointments have been scheduled. And Brian has not used the emergency department since joining the Care Management Collaborative. So we know this is possible. I'd like to close with this 3-minute video clip that illustrates how a bold idea can be transformed into something that is universally embraced and accepted by an entire community. Give me a minute. Your presence here today takes us beyond the shirtless dancing guy with 1 follower. The second follower is the turning point, 3 is the crowd, and now we have a movement. So thank you for coming. I'd like to introduce Laurel Ruggles, the Vice President of Marketing and Community Health Improvement at Northeastern Vermont Regional Hospital, and one of our original first followers, if not a lone nut. Laurel has over 20 years' experience in healthcare administration, including medical office operations, marketing, and community health. She has been the project manager for the St. Johnsbury Blueprint for Health since 2005 and is the architect of their local community health team. Please welcome Laurel.
So good morning. Thank you all for coming. When Pat Jones asked for somebody from St. Johnsbury to speak to you today, I think what she really wanted was for someone to come. You know, we went through this collaborative process starting about 9-10 months ago, so we're just a little bit ahead of you. And I think she was hoping that we'd be able, someone from St. J could come and talk to you today and maybe lessen your learning curve a little bit, so that things that maybe took us months to get to, you'd be able to get to in maybe just a few weeks or days or by the end of today. So I was trying to think, you know, how can I express that in a PowerPoint slide? And I thought, well, maybe I can find some inspirational or famous quote that would do it. So I got on the internet and looked, and I found this one. So as I said to the group yesterday, you can either take my advice or not, but it's up to you. So the first thing is, and it's kind of obvious, but you've all been part of the Blueprint communities and community health teams for quite a while now. So because now you're starting this new learning collaborative, that doesn't mean you start from scratch or start over again. You want to really start from that base that you built, the infrastructure around the community health team, and probably even more importantly, those relationships that you've already formed with other members of the team. So just, keep that in mind as you're going forward. You're not starting from square one. So this is a little bit about our community, and these are the agencies that we brought to the Learning Collaborative. So the ones who actually had the advantage to come with us on these collaboratives and also sit in on the webinars as well and do the work. Who you decide to bring, because you can't bring everyone in your community, is really going to depend on what population you decide to work with, and also who wants to be at the table. We ended up working with the population of people who were duly eligible for Medicare and Medicaid. And some of these agencies like VCCI don't even work with duly eligible, but they really were willing to be at the table, willing to help where they could. So we said, great, come join us. The other thing to remember, because you can't bring everybody, is you've got to figure out, have the advantage, you're able to come and listen to great speakers from around the country, like people from the Camden Coalition today. Take that message and what you've learned, the goals and objectives, the tools you're learning about, back to people in your community. How many people here actually do direct service? Okay, so probably not even half. So there's going to be, as you're working with people in your community and trying to work on better building those structures around care coordination, there's other people in your agencies that aren't here today. So make sure you figure out a way to build in how you can take the knowledge that you're gaining from these collaboratives back to them. I just want to say a little bit about the Learning Collaborative process. We've always been a big fan of it in St. Johnsbury. It always helps us take that time to get together and move something forward. But I'm not going to kid you, it really takes a lot of work. This is extra stuff. You've all got jobs to do. This is extra. It's going to take extra work, but it's really worth it. And the other bit of advice around this, and I'm going to quote something that Sarah Narkowitz from Rutland was talking about just last week when we were on a call talking about planning this day today. And she said, just remember, this is about focusing on the process, not the patient. We're all here for the patient, but the time when you're at the collaborative, you need to be thinking about the process. And that's not always easy to do when, you want to be right in there helping someone or helping people in your community. This is a chance to step back and think about, how can we work on systems? How can we work on improving those systems, relationships, so that then we can do a better job when we're working with individuals? The other thing, because there is a lot of work involved, and I asked our group, I said, what kind of advice can I give around that to kind of spread the work around? We had two co-chairs of our group. We had Pam Smart and Trenny Burgess. They found it really helpful to have two people just to spread the work, but also, some of the responsibility. And also, they always couldn't be here at the collaboratives. They couldn't always be at our local meetings, so they could split that up. So the work kept moving if one of them was tied up with something else at their regular job. The other thing is we assigned someone to be an administrative assistant type person, Laura Rooker, and she's not an administrative assistant. She's actually practice operation manager for the hospital operated practices. But she took on that role of updating spreadsheets, trying to keep our forms and things complete. And so that was really helpful to have somebody in that role. You're going to be learning a lot of new language. We found that there were things that we were doing that actually someone else in the country has come up with a term that describes it, which is really helpful. When you can suddenly just describe what you're doing. You don't have to do a long explanation. You can say, oh, we're finding the root cause of medical, psychiatric, social, or system. What is the root cause of what's going on with this person or this family? So that's really, really helpful. You're going to hear from Camden today. We adopted what we call their Camden cards. That's a tool that we didn't use before that we're able to use now that's been really helpful. Some of these things you might have used before. You might have used EcoMaps. You're going to get more examples of that and how to use it. So you're going to just learn a lot of new things that you can add to your toolbox. So this was our project. We decided to focus on the duals. We applied for a innovation project subgrant, which we received. The idea to apply for the grant came from our Unified Community Collaborative, which I think all of you have and may be part of. So we're trying to tie that together and think about that as you move forward and decide who you're going to work with specifically for this pilot project, because your UCCs may have already come up with some specific goals and objectives and people that you want to target. If you can tie that in, that helps. It helps move all the work in your community forward. We had the same learning collaborative objectives that I believe you do, so that didn't change, even though we might have had a different population. And I want to talk a little bit. I know I worked with a group from Brattleboro yesterday where they're still trying to identify their pilot population. We did a combination, and Brattleboro was doing the same type of thing of looking at the data. So we all have data, whether it's from the ACO or your internal measures or whatever you're looking at. So we looked at we decided we were going to use the duals, and so we looked at the highest utilization people on that list, but we went a little bit back and forth. And because we also, from each agency, they had people they knew off the top of their head who were some of the people who would really benefit from being part of this. And so we went back and forth, using the data and using the gut. And that was a good balance to come up with the pilot population. The other thing I would say about that is it's not as if, these people have won a prize and, oh boy, you get to be in this project with us. These are just the people that you're going to measure and you're going to track for this particular learning collaborative, and you're going to keep stats on them and pay particular close attention to them. But as you start to develop tools and new systems, you don't have to wait. You can go out and use them on anyone. You come up with decide you're going to use the Camden cards or a shared care plan. Don't think you're just confined to these 25 people. Go ahead and use it on other people, but you're just measuring and tracking these 25 people. The other thing that I would suggest is you don't necessarily have to take the highest risk or the highest need people. You want to be able to test things that you're working on, and sometimes it's easier to test things if you're working with more low or moderately at-risk people. So I would suggest you get a combination. I think our instinct is to we want to help the ones who need the help the most, but sometimes it's easier when you're testing things to try on someone who's maybe a little bit easier to work with. So I'm just going to go back to this one for a minute. So each one of our agencies, the lead agencies that were involved in here, came up with a list of people that they nominated, and we whittled it down to about 25 people. That person who nominated from the agency who nominated the person for this project became the default lead care coordinator. And that's just how we started. They were the person who approached the person to see if they wanted to be involved in this collaborative, got them to sign the waiver. And so that's how we immediately had 100%, everybody had a lead case manager, because that's how they were assigned. If you nominated the person, if you knew the person, then you were the lead care coordinator for them. I'll talk a little bit later how that doesn't necessarily mean you're going to be the lead coordinator forever. This is very much around about the patient, very much around what the patient's needs are, what their priorities are. And you're going to get some tools, as I mentioned before, that will help with that process of making sure this is patient-centered. You're just going to add these to what you're already doing. Many of you are already using self-management techniques. You're good at goal setting, action planning with patients, doing motivational interviewing. This will allow you to just add a few more things that will get at making sure that the patient or the client is a very important part of the team. So one of the very first PDSA cycles that we did after coming out of our first learning collaborative and learning about what Camden was doing, and you're going to hear much more about this later today, is we took what we're calling the Camden cards. I heard they don't call them that, but that's what we call them now. And which they have their domains of health. And it's really a way of engaging the patient in an easy way to figure out what's important to the patient to work on, what can be saved for later. So we started using them right away. One of the first changes we made is we decided to add pictures, and we made a few other tweaks. So this was really textbook PDSA cycles. Rapid cycle, used them, started using them right away, tried them, got some feedback from people using them, feedback from the patients. Really did a great job on that, our first PDSA cycle out. Then we got to our shared care plan. Not such a good example of what to do. We started working on the shared care plan right away, because we knew that was a big goal of this collaborative and we wanted to get this done. It took months and months and months and months and months before anybody even used one on a patient. This is it. It's a one page. It's basically a snapshot of the patient. It's, basically who they are, who other members of their care team are, what their goals are, what their treatment goals are. We kept tweaking it and tweaking it, changing a word, moving this to that, higher, lower, whatever. Nobody, they wouldn't use it. I don't know, people were afraid they were going to be graded on it or something. They just couldn't get them to use it. We finally, and I'm about 6 months into this, so we finally said, you just got to start using it. We don't know if it works. We don't know if people are going to like it. We don't know how you're going to use it unless you start to use it. So make sure you do that quicker than we do. So we're using it, and I think I think everybody's got a shared care plan at this point, everybody who's in the pilot. There's a few things we haven't figured out yet. They're sort of done in their own silos. So each lead care coordinator has a shared care plan with their patient or client, but we haven't figured out a good way to share that. We haven't figured out how often it's going to be updated, how often you're going to talk about it with other members of the team. Those are all things that we need to continue to work on. And hopefully you'll be able to do that quicker than we can, and then we can learn from you. So any advice you have on that as you go forward, we'll make sure we get that. Maybe we can speed up our process. Our next steps with the shared care plan is we think it would be very important to be able to embed this wherever it's coming from in the hospital EMR. So when people come into the emergency department or they get admitted into the hospital, they know that there's a shared care plan in place. They know that there's community agencies, other organizations working on this. We have been able to, in the hospital-owned medical homes, they have electronic version in their EMR, which is great. But it's only, so it's great for the care coordinator who's in the practice. It's great for the PCP. There's no way to share it right now with the ED, the inpatient. There's no way to share it with the other community agencies. So we've got a ways to go on that. So I want to talk a little bit about why we're actually doing this work. Here's a case study. BL, I'll call him Bob. And he's a dual. He's on Medicare and Medicaid, but he's relatively young. He was a local guy, athlete, went away to college, had a promising career as in baseball. He actually had a tryout with a major league team. And while he was away, he had a diving accident, and he's now became a paraplegic. So I got a lot of information on here, and some of it will be kind of a giveaway, but what do you think was the most important thing to him? If you can imagine, you're a 25-year-old male. Somebody said driving. Yeah, exactly. That was his main thing. I mean, I think back to, I think it was a Chevy commercial or GM commercial where they talked about it's not just your car, it's your freedom. And just feeling, I didn't get my first car until after I graduated from college, and it was like, this is great. Finally I didn't have to bum rides. I used to hitchhike back then too. It was a long time ago. So yeah, it's everything. You're a 25-year-old guy. That makes all the difference. And so also, if you can think about the different agencies, the different partners that had to come together to make all of this happen. Lou is his lead care coordinator. Lou works in our Community Connections department, but Lou couldn't do this alone. He had to pull in many other agencies in order to make all these things happen for Bob. And he's doing great now. He can get in and out of his truck. He can drive where he wants to. He started volunteering at our local youth services agency. He coached baseball at the high school in the spring. It's made a huge difference, made all the difference in this young man's life. So some of our lessons learned, as I mentioned, your lead case manager may change as the individual's needs change. Also, we had a few surprises where somebody was so sure, they've nominated this person, they were sure they were the main person in this life, they were the perfect person to be their lead case manager. Come to find out, in this one particular case, they already had case management services with our mental health agency, and people didn't know. So either you're going to get surprises or just the needs of the patient may change. And so you need to be flexible and be able to, give up that lead role as needed. We didn't have a huge problem trying to recruit people for this. It's all in how you present it. If you tell somebody, we're going to tell everything about you to everybody, then obviously they're not going to want to be part of this. And you'll find that some members of your team are much better at really selling this and talking about this is about making your life better coordinating your care. So we actually had to come up with a script because not everyone was real comfortable with that process. Here's some of our challenge. I think one of our biggest challenges is we had some organizations that we brought in, we're working together, and they didn't have the capacity to provide the services, or at least not as quickly as we identified them. And so that's the reality of life. Sometimes you can't get things done, even if there's an agency that's out there, even if you have money in order to pay for the services, you might not be able to provide them right away. That was probably the biggest challenge that we had. Here were some of our opportunities. We did get extra funding because we got that Innovation Project grant, but don't let funding be a barrier. We also found that when you start working together and talking about things that patients or clients need, that you might have agencies that have alternative fundings, and we actually found that more often than you would think. Here's some of our recent accomplishments. I'm not going to go through them, but I would urge you as you're going through and doing this work to keep a list, actually write things down and talk about it and pat yourself on the back, because you're doing really good work and you've got to celebrate those accomplishments. So here's my final word of advice. Ever since I learned about PDSA cycles, I don't know how many years ago, anybody who knows me and works with me, I'm always saying this, don't get stuck in P. The planning part really bugs me. It's like, let's just do something. But I think it's really don't get stuck in any one of these quadrants. You can't always just run off and do something either. So have a nice balance and go through your PDSA cycles. You don't have to spend the same amount of time or energy in each section, but keep moving. So that's it. Does anybody have any questions? Are you asking about what our data source was? Is that part of the question?
Yes, and then if you don't get enough in one data source, do you or do you not recommend using other data sources?
Yeah, I think we get the advice a lot. If you're working with the Blueprint or ACOs, you want to get those high utilizers. So we're kind of always thinking about that. We actually went to the Blueprint Medicare portal because everybody that we decided to use the duals and they all had Medicare, and so they're on there. And there's risk scores on there. It also tells you how many dollars have been spent on medical care. So we looked at that. But as I mentioned, it was really an iterative process. We also just there's people that just come to mind. So I guess, and I think other people besides me give this advice as well, you can't always just pick the high utilizers. I think it's a good place to start, and maybe that's a good place to get your list to start with. But I do a combination of just, who do you think is out there who could use extra services? Does that help? Okay. Yes. Right now, except for in some of the medical homes, and even if it's embedded in the EMR, they're really still using a paper copy. There is some work being done at the state level to do have a format to do a statewide care plan. There's actually quite a bit of work going on with that, whether they use the Vital as a platform, and there's different groups around the state that are working on that. We're not quite there yet. I think as you'll hear from Camden today, and when you hear from some of the other speakers that are coming up, there's not a lot of good solutions yet, unless you're a real closed system. But when you're talking about medical care, so we have EMRs, but most community-based agencies don't. Maybe they have their own database, but we're not connected. So don't let it stop you from doing the work. You'll think about, this is going to get us a little bit closer. So now we're going to have a shared care plan. We're going to have everybody using the same thing. We haven't figured out a perfect way to share it yet, so it's not care plan shared in quotes, but we'll get there. Yes.
Can you speak more to how information is shared in the shared about patient influence, how you went about doing that?
To pick the pilot population?
So I guess sharing the information with the population and then overall sharing the information within the team that worked on it.
Mm-hmm. Are you talking about making sure you have the right waivers in place and all of that? Yeah. So we had a lot of discussions around that, because we came up with a waiver specifically for this project for people to sign, but that did not override individual agencies that had waivers. What happened, a good example is the mental health agency is probably the most concerned about sharing. So as we were starting to recruit people, it turned out we ended up with 25 people. It turned out that it was 9 of those people were actually getting services through a mental health agency. So once the patients were recruited and they signed the waiver that we could share information, then the mental health agency came forward and said, we're working with that patient. We got them to also sign our own internal waiver. So now we can all work together. But it was a little bit of a secret there for a while in order to make sure everybody felt comfortable that all the permissions were granted. It was just back and forth. It was people nominating and then starting with a list that came from who are the high users, going back and forth. It took, I think it literally, it took 2 or 3 times of going through it to come up with it. The other thing, we started off with 30 nominees, and so I would kind of oversample to begin with, because these were nominations, but then people had to go out and recruit them. Not everybody wanted to be involved. We actually had 2 people who passed away in just the few weeks between coming up with the list and going out and recruiting them. So oversample a little bit so you've got enough people in your pilot. Yep.
So the nomination discussions before the waivers were signed?
Well, some of the people were already working together, and so they had some waivers already. But we had to, before anybody's name was shared, we had to make sure we had the right things in place. Yeah.
That works in your hospital. What is that?
Oh, where Lou works for the Community Connections program?
What does he do essentially?
So Community Connections is a program that is made up of, we have 4 community health workers that work in that program. And they've been around since 2002, and they're not medically trained. So their main thing is to try to connect people with resources that are in the community. They do kind of interim case management. They're not case management themselves. If they're working with someone who truly needs case management, then it's their job to get them to that agency that can provide those case management services. Okay. Yep.
non-case management follows all the people from. Did you have those conversations, and how did you come to a decision about that?
Yeah, I mean, luckily we didn't have any fistfights about who was going to be the case manager. Yeah, there was. I mean, the one example that I gave was we had Lou. Lou was actually thought he was the perfect case manager for this young woman, and then it turned out that she had a case manager at mental health, and so then there was a discussion, and it became clear that it really should be that the person at the mental health agency that had the longer term relationship and would be the better lead case management. And that didn't mean that Lou backed off totally. He was still part of the team, but it switched over. Exactly, the longer relationship. And Lou doesn't do case management, and she actually had a true case manager. Okay. Yes, that's a very good point. Thanks for bringing that up. Yeah, they definitely are the tiebreaker. And that's one of the things that some of the tools like the EcoMap can do for you. They can identify who's working with you and who's working with the patient and who they feel the closest connection is and who makes sense at that time to be the lead person. Is anybody over here? I feel like I'm neglecting this side of the room. No? Okay. Is somebody here?
Yes, I'm the director of the Turning Point Center in Addison County, which is, I don't know if you've heard of it or not, but we're a peer-to-peer substance abuse and addiction agency. And that's one of the concerns. I think Lou, we're talking about Lou, he's not a mental health provider. We're not mental health providers, but we are recovery coaches, peer support organizations, community recovery coaches and stuff like that, you know. That has been a little bit of an issue in Madison County. Maybe I think it's better than, put up speech on that. But what has happened in other areas or in your area? Is there anything you know about working with?
Mm-hmm. Yes, we have the Kingdom Recovery Center, very important partners with us. One of the community health workers has a real close tie to the recovery center, Steve, and he's we use them quite a bit. Yeah, so that's great that you're part of this team. So I think Nancy, am I getting a gong here? Okay. All right, I'm around all day if anybody has any more questions. Thank you.
Thank you. Laura will be around later today if you have questions. Again, these questions illustrated what happens in a learning collaborative. Laura's one of the communities who has gone before. We can learn from her, and what's really amazing, she can learn from all of you. So that's what we want to keep going, is this shared learning throughout the time that we're in the collaborative. So I would like to introduce two women that we are just delighted to have with us today. If you did your pre-reading, you can imagine why we're delighted to have them. Kelly Craig and Victoria DeFilio come to us from Camden. Kelly has an MSW. She supports the design, development, and expansion of the community-based care management program involving multidisciplinary outreach teams. And Victoria is the clinical director for the Camden Coalition of Healthcare Providers, and in this role she provides mentorship, training, and oversight to two primary care-based multidisciplinary outreach teams. So Kelly and Victoria.
Hi everyone, I'm Victoria. So we are going to start off with something a little unconventional. We would like you to huddle in your teams and split by direct service people and admin people. And we're looking to have you answer the question, what keeps you up at night? So if I said, we canceled this conference right now, you would say in your head, thank God I can go work on, we want that. So we're going to give you 2 minutes to do this because I want the first thing that comes off the top of your head, and I don't want you to talk about it too much. And then we're going to go around and have everybody share. We are going to do our best to tailor our presentation to that. Okay, so go ahead. So direct service and admin folks. So split into those two groups within your communities, and we'll share the mic. All right, the 2 minutes is up. So I'm going to ask you to stay where you are. Stay where you are. And where's the portable mic? Do we have the portable mic? Oh, great. Okay. So we can have this group over here. I need somebody who has a really loud voice. Come on up, actually. We'll start. They paid extra for the rotating mics.
All right, so we're the direct care providers. We're concerned about if patients are getting the follow-up that we have recommended for them. So referrals to specialists or seeing their primary care doctor, and is that handoff happening well? And worrying about those sick patients at night of, are they getting to the next place appropriately?
This group. Can you say what community you're from also and whether you're admin or direct?
Yes, hi, I'm Susan Bruce from the Middlebury Health Service area, and we are the admin group. And what keeps us up at night, and if this were canceled today, we would be working on our 16-item to-do list and a quality dashboard, and did we hear from any? Oh, and a grant.
Okay. Group in the back over here.
And working on, go ahead.
Spending a lot of time and effort planning things is never
Let's make it happen, people.
The next group. Did we get the patient side of? No. Okay.
We talk about our most at-risk patients, staffing issues, access for those patients, paperwork, general paperwork.
Okay. That's great. I get it. Group in the back.
Direct service side came up with concerns over housing to people that we say goodbye to or in the state tonight. Poverty, communication between providers about high-risk patients, diabetics, suicidal ideation, that sort of thing. Paperwork.
Okay. The admin side?
Admin side, if this was canceled, I would be dealing with staffing issues, appropriate documentation, communication between practices and Medicare regulations. Changing daily.
This group here.
You're looking at me. We're looking at you. We didn't really break up. So this is Franklin County. So part of it is, at least at our table, we're a mix of admin and clinical. So although I'm an administrator, I also see a panel of clinical patients. So I think that I have a huge to-do list, and that's what I think the table said. There's a huge list of administrative things that we've done. We didn't go into detail as well as everyone else, but I'll second a lot of things they said. And then certainly from the clinical component, it would be catching up on notes, treatment plans, documentation. That would be the first thing.
Okay. So the two big things that I'm hearing are, and shout out if you want to add, I'm hearing communication between organizations. So what happens after I hand out patients, where do they go, how do I deal with that, and also staffing in general.
Can somebody tell me a little bit more about staffing? Is it, what is it about this community? That you don't have enough, that you are worried about the training?
It's really difficult to find people who are qualified, who work for what we can afford to pay them, who, will stick around in our staff, so that because of the turnover, that's what I'm just to fill positions. It's hard work.
Burnout.
Yeah.
Just a comment as a direct service guy. I also heard a number of direct service people say notes, data. And I guess I just wanted to say a little bit of sadness about that. I also have the pressure. It didn't rise to my consciousness that, oh, I'd rush off and do notes, because frankly, it's not what I would do if I had the day. But I also have the pressure of that, and I just think we need to be mindful of that with the processes we create, that we don't create more data for ourselves to do. We have quite a bit that's not, I think, being used well enough already. So I have a little sadness about that.
I heard that. I hear that too. And I think today that's not something that is probably appropriate for an outside organization to cover, but it's definitely something I think that folks are hearing and that we can chat with them about afterward. All right, so I'm going to let Kelly talk about the triage, and this is going to give me time to brainstorm about the framing about communications between organizations.
Thanks, Victoria. So as she said, I'm going to give you guys a brief overview of what was a project many years ago and now is actually a program within our organization. But just to give a little background, my name's Kelly, and I am the Senior Director of Care Management Initiatives at the Camden Coalition. So my background's in social work, and for the most part, I've done a lot of community-based healthcare. And my job now is I'm the program director. I do a lot of operations. I do all of our hiring, staff development. So, and Victoria's department really does a lot of workforce development and technical assistance for collaboratives like this all over the country. You guys are very unique in that you're really looking at communities and bringing those communities together without a lot of money, without a lot of resources. But I think just the fact that you're all here is huge, because that is a lot of the tough work that we've seen, and especially when Victoria has gone around and worked with some of these various groups. So I'm going to give you a little bit of background on our project, and hopefully it'll just generate some ideas that you can use for your communities. It's not meant to be anything you take and implement. This is what we develop for our community. And then we'll have some time for questions, and then we'll move forward. But I think you will find some strategies that we've developed to help with our staff burnout and what we've decided to really focus on to help move our work forward. So I hear what you guys are saying, and we are going through the same thing, and we've been through those same issues. So this is our lone nut, our fearless leader, Jeffrey Brenner. And he came up with this idea of healthcare hotspotting. And hotspotting itself is segmentation. It was used in New York City to segment certain areas to reduce crime. The Commissioner Bratton implemented it. And we've taken this within Camden, our 9 square mile community, 90,000 people. And we've tried to use data to target different groups to be able to reduce costs, but really improve quality of certain groups within our community. And it's as he said here, it's making sure that people who are in need get their needs met in a data-driven way. One of our core values is to be data-driven, and that doesn't mean we always have access to the data we need. But we do want to work on issues that our community has identified through the data sets we have available to us. And so that's what drives a lot of our initial processes. So this is an example of segmentation, right? We're always looking at our customer base in capitalist societies. We can segment. We're not going to target a community that doesn't want a certain program or service. So we've tried to do that with what we're offering. And I think it's important to think, what doesn't exist, whose needs aren't being met as you're trying to develop these collaborations. So we focused on high utilization, which is a challenging in itself, and then we've also targeted complexity. So as opposed to just looking at single disease states, COPD, diabetes, heart failure interventions, we've combined them all because the folks in our community have all of them. It's not just one disease state. They have a complex medical needs and social needs. So we're looking at high utilization and complexity. I don't know what we were thinking. So they're right when you want to think about maybe targeting an easier group. But on average, the folks in our community have 5 or more chronic conditions, and that's not including substance use, diagnoses, or mental health issues. So that, when I talk today, this is the population that we've chosen to focus on. And this is the problem that we're all trying to solve, right? Uncoordinated patient care. The systems that we work in are very, very fragmented. We need to create better collaborations and better bridges to be able to navigate this. This is just one patient we worked with, and all of the things that he needed to get coordinated in order to maintain his routine medical care. And it was a very complex process. Eventually, we were able to help him, get into a day program, get into mental health counseling, get to all his specialty care. But each step represents a part where that could fall apart, especially if they don't have folks like you trying to help navigate this system. It can be very confusing. We've all been in these situations where we have had bad experiences, and we've become very disillusioned with healthcare as it is now. So I want to just talk about patient engagement because it's the backbone of everything we're going to do. But when we launched this project of working with high utilizers, looking at complexity, how do you get people in the community to buy in? Because you do need their help. You need that mental health provider that's going to get that patient in to seek counseling. You might need, various hospitals to communicate with each other because this person is going to all of the EDs. So when we started, it was back in 2007, we just started with a citywide meeting. And this meeting was frontline providers that we personally invited to just try and problem solve barriers they were seeing with certain patients within the communities. And then we really started framing it around our patient population. Well, who is going to all of your hospitals over and over again, and what are their needs? So from there, we started doing individual case conferences. They were anonymous, just to look at root cause and why people were going back and forth between all of these institutions. And then we constantly were looking at who's not in the room, who needs to be a partner. And we really wanted to focus, are we having a lot of veterans? Do we need veteran services in the room? Home health providers. So it started with like a group of 8, and now we have about 60 people every month. And we're constantly bringing in new people. And the way we've structured that to get buy-in is we're definitely, our region is Camden, so we're focused on Camden City. But we do a lot of networking, so the first half of the meeting is sharing a resource that everyone can access, even if they're working across different populations. And then we stick to that individual case conference to really identify the barriers to also bring out the level of collaboration that needs to happen across the community. And so as we work as a group to help individuals that might be identified in that meeting, we come back each month and say, look at this success we had, collaborating across the city. And that has helped just continually meeting month after month and growing that project and really forming, getting support around our idea, and really trying to be able to help communicate that we weren't there to interfere or override other people's jobs. We're in this to help each other and really look at what are the problems our community is facing as a whole. But so the backbone of when our care teams are working with patients is really the relationships. we can have all the data we want, referral sources, funding, but if we can't form relationships with people, we are not going to succeed. So a lot of what we've learned, I will say, is being able to drive that process. And so I'm going to keep going back to that as the theme because it wasn't always so intuitive to us as a group to really look at that relationship factor. But before we started, we really had to identify, we knew who we wanted to work with, but when we started, we didn't have access to a lot of data. So we went around to local hospitals, frontline service providers, and we said, well, who's your most difficult patient? And we got a lot of buy-in that way, but we wound up having a huge patient panel with people that had very complicated situations, but they weren't necessarily expensive. They didn't have high healthcare dollars, and the point of the program was to save healthcare costs. So we needed to have more of a rigorous way to identify people that met that criteria. So eventually, through our health information exchange, and this is over several years, we're able to get a daily feed of everyone admitted to the hospital within our community that is a Camden City resident who has 2 or more chronic conditions, which is what we established as our criteria in 2 or more admissions within 6 months, because over time we were able to see, you know what, this is a pattern, we can handle this, and it helps us focus in, if they meet this criteria, we are going to attempt to work with them. So it makes it very clear. When we did not have that very basic structure, we were all over the place. Our teams were stressed out, we were losing focus. So having that put in place made all the difference. And then having the technology on the back end really helped. But we have a triage process. So 2 inpatient hospitalizations, they can have any number of ED visits, and they have to live within the city. So the first thing we do is we created a rule out process. So who are we not going to work with? And this is fairly minimal, but we rule out oncology patients. So if the admissions are related to oncology, because we found we weren't successful with that group, there wasn't a lot we could do to prevent those inpatient admissions. So we ruled them out. Acute conditions, so if someone's going into the hospital for pneumonia, it's not related to a chronic disease, we ruled that out. For illnesses that are progressively going to get worse, there's not a lot we can change in that process, we rule out. So it's very minimal if they live in a nursing home. So we look for that rule out criteria, but then we're really looking for rule in criteria. So they have 2 or more chronic conditions. Unfortunately, that's pretty easy to find within our community. Are they currently actively using drugs? Do they have a housing barrier? We have access to the medical records within the 2 admitting hospitals within our community. Are they labeled in the notes as we're reading notes? Does it say non-compliant? This patient is difficult. To me, that sends a red flag that maybe that person's not being heard. And we like a challenge, so that would prioritize someone. Are they on a ton of outpatient medications, 5 or more, 10 or more? And do they have support? So if family members are in the room, they're involved, maybe they are less likely to get readmitted. But a lot of times folks are isolated, they don't have a lot of support. So those are all the factors we use to prioritize. So we really are looking at vulnerability within that, to define our complexity. So that is our target group. So once we triage that list every day, we triage that every morning, in real time, we assign out the patients who we've identified as eligible for the program, and we have a staff member that goes straight to the hospital, either hospital, to offer our program and our services to them. And we used to go door to door to door, and it wasn't that efficient, and it was somewhat scary because sometimes there are very scary dogs that might try to chase you. So this was a real opportunity, because when folks don't like being in the hospital, and they might be cranky and difficult to engage, they don't know who you are, but they're there. It's a window of opportunity, and we can say, do you want to stay out of the hospital? So that really helped us increase our enrollment and really be able to start building that relationship. So right off the bat, they know we're going to wrap around them, we're going to work with them once they get out of the hospital, and we can start that discharge planning process to really meet their goals moving forward. But it can be really challenging, that initial engagement. So I'm going to show you a video of one of our staff members, Margarita, and her thoughts on what it takes to engage folks, especially in the hospital setting, but I would say in any setting.
My name is Margarita Santiago. I am their enrollment coordinator, and I am hospital-based, and I engage patients at the bedside.
Okay. So you get the name of a patient to go from our triage department or from the triage process, and then you go to one of the 3 hospitals and visit them. So what's the first thing you say when you would go into a patient room?
Well, first, I make sure that I'm dressed appropriately. I think that's first most important, that you're not overdressed. Some people may take that as a little pompous, I feel, especially in this underserved community. So you have to sort of fit in with your community members. That's first. Secondly, once a patient is triaged to me, I check to see what their background is a little bit based on their admission diagnosis and so on. And I ask permission to even meet with them. I ask them if it's a good time. Can I sit? Put your purse down, get comfortable. I always say I kind of sing when I speak. I make them feel, I soothe them with my tone. You have to have a specific tone when you walk in. Never hover over the bed. Sort of be at eye level. Make contact if you can. If it's allowed, make some kind of contact, whether it's holding their hand or whatever the case may be. So my specific attitude going in is that the person I'm going to see is a family member. It's my sister, it's my brother, it's my grandma, whatever. So you have undivided attention and love for that person, and you don't even know them. So that's my attitude going in.
That's great. And then what would you actually say to them? How would you describe the program? Do you start off by asking them how they're feeling? Can you talk a little bit about how you get into that interaction?
Sure. I would say, Mrs. Smith, my name is Margarita. Sometimes I'll just throw in a joke and say, like to drink, so that they don't forget my name. And I'll say, I see that you've been coming in and out of the hospital quite a bit. I'm a Cooper employee, so I make them feel kind of comfortable with who I am and that I'm part of the hospital institution that they chose to come with. And I'll ask them, I'll let them do all the talking at the very first 3 to 5 minutes. Let them tell me about themselves. And then I come in and tell them, well, this is why I'm here. We engage with patients that are a lot like you, coming in and out of the hospital, that may need additional services once they have gone home. So I'll explain how we have a multidisciplinary team of a nurse or LPN, social work, and so on, and what each person does or can do for them if they would accept us to give them that type of help.
Okay. So a question that we get a lot from teams who are just starting out is, what happens if the person says no? And how do you navigate that?
Right. Well, I always ask why they said no. What is it that they didn't like about what we've said? Is it that they have enough help at home? Okay. Some people do just have a lot of help, and it's inevitable that they come to the hospital. And we have to respect that. So depending on what the objection is, that's how I navigate through that. And, you know, if they say that their family member takes them to the hospital or takes them to their doctor's appointments, I will say, well, let's try to give your family member a break, because even though they mean very well, they might not tell you, but they might be a little tired too, because we all get tired. And sometimes they'll say, you know, you're right, she does miss a lot of work because of me, and so on and so forth. So really it does depend on the objection.
Okay, that's a good
Great. And then when the patient's family is in the room as well, how do you involve them in the engagement process?
Well, I encourage the family to be there. If someone has a power of attorney, a POA, I'll say, you know, what's the best number to reach them, and I will encourage that person to be in front so that they know that we're legitimate.
Yeah.
Some people look at you, you know, with a slight crooked eye. Who are you? Why are you here?
Right.
How do you know anything about me? So if I tell them I am a hospital employee and that I would love to meet their family, it breaks down yet another barrier.
Okay.
So when I meet with the family, I address them both and I ask them both their opinion and I get them both involved in the conversation, and then from there is pretty smooth sailing.
Okay. Great. So this is all really good stuff. Is there anything else you want to add about what you do or your role?
I think that when we meet with patients, we really, in the words of Jason Turi, my boss, he says, you know, we have unconditional regard for our patients. And they need to see that with your demeanor and always with respect and non-judgmental attitude. Knowing your community does help. That's another angle. If you engage and you know their doctor, their family PCP, or you know where they live, and you can really add something of value into your conversation, 9 times out of 10, they're going to trust off the bat.
Okay.
All right, so thanks for your patience on that. So participants that you're going to enroll, as I said before, into your various programs, I've unfortunately had staff that didn't feel that way about each person. There were biases, there were judgments made. So that's a important learning process that we've had, and I'm happy to share some of our hiring practices. I didn't build it into this presentation with anyone who wants it, because now it's much more rigorous. And that's been a lesson that we've learned over time. But just to get back briefly around our intervention and how we engage people. So once someone's discharged from the hospital, we go into their home. And unfortunately, we are a temporary program, and I know a lot of care coordination programs aren't permanent. So from the beginning, we're constantly trying to figure out what's that long-term team, or what's that long-term resource that's really going to be there when we're not in the picture, and how do we start coordinating and collaborating from the very beginning to find who that person is. You know, do they already have a case manager in a mental health agency? Sometimes there can be so many silos, especially within our community, and we're really trying to break those down. Is it their primary care provider? Do they even like their primary care provider? So these are the things that we're trying to determine from the beginning. But once we're in the home, we do a brief assessment. We don't get a ton of information because things are constantly changing. But we really do want to start goal setting, what the patient's goals are, and how we can move some of those things forward. We really want to be centered on those patient needs, because when we've tried to put our own thoughts and opinions on what's going to change, it's not their priority. So we really try to create that process. And we will talk a little bit about our backwards planning cards, the Camden cards that were mentioned earlier. That's really helped in goal setting. So we often accompany patients to primary care providers, specialty visits if they want. We have a goal within our city to try and get folks into the hospital, coming from the hospital into the primary care provider within 7 days. It's called the 7-Day Pledge. That's for part of our ACO work. But either way, we've seen that if we can help bridge those relationships, that will help in maintaining someone's stability and ability to stay out of the hospital. And sometimes it is, you know, they've never been to the primary care provider they were assigned to, or the person they went to left and they got picked up by someone else. So we really do start having that conversation. If they need to go to the Medicaid office, we'll go with them. It's sort of as in, what are the goals? What's needed? Does the person even want us there? Sometimes they don't. So, but that is something that we provide to try and continue that relationship. Then we graduate folks. So on average, it's about 90 days in. Sometimes it's much, much longer than that. And it just depends on what are the goals we're working towards and how do we make that happen. And, as you can see here, we give a certificate, and that seems really hokey. And at first I was like, oh my gosh, I don't know if this is going to work. People love it. So just an acknowledgement of progress, I think, and that when we're encountering people, they're in a very vulnerable moment and that they've come out of that situation can be very powerful. So we have, we try to acknowledge that progress that's been made in whatever way possible. And if we can include whatever that long-term team is it a person, is it a resource, in that process, we do. We've connected, we're very close with our PACE program. I don't know, do you guys have PACE here? Oh, no. Yeah, so programs of all-inclusive care for the elderly. We connect a lot of people, and they do wraparound services, really try to keep people in the home and out of nursing homes. And so they'll come with us to graduations, and that's been a really, really good partnership. And we're constantly looking at how can we build those partnerships. We just created another one with a local senior high-rise building in our community, and they have a social services team. And once we're sort of wrapping up some of our goals, we start looping them in onto the progress that we've made and some of the things that might come up in the future. So once in a while they get frustrated when calling transportation, if you could just be there as a resource. So that's been, all of these partnerships we're constantly trying to leverage. And as people come and go, sometimes that can change, but we are continually looking at how do we work with our community partners to do that. So our model isn't new, just like none of this is new. We've stolen everything that we do from ACT programs, Ryan White, all-inclusive care, when following people with HIV/AIDS. So we have just understood that really looking at patient goals and being able to help someone navigate through this system really does work and really does improve the quality of care that they're receiving, and hopefully try to reduce money, healthcare savings in the process, because we all know that that's really what people are looking at. But we really want to think about if we can't get people who want to do the work, if we can't get people who are invested, then you're not, you're going to fail immediately. And so that's where I wanted to share with you some of our lessons, because there's no reason to keep making the same mistakes that we have definitely made over the years. And this is my team now. They're a cute bunch. So as I said before, we have a mix of nurses, some are LPNs, some are RNs, social workers, program managers, community health workers, enrollment specialists who have various backgrounds, and AmeriCorps volunteers, which has been a really, really valuable resource that we've leveraged. They rotate about every 10 months in our program. But, we had to get there. And so we also had to hire the right people. And, we have made the mistake of hiring people. Unfortunately, they weren't empathetic. They did have biases. And sometimes that can be really hard once someone's in there. You can't necessarily change someone's mind and tell them, can you just like someone that you're working with, please? So we have a really good hiring process that's very lengthy, but we do a group interview process, and we show certain videos and facilitate conversations around them, because that can get at people's personal biases fairly quickly. And from there, we have several other interview steps, because we're not really thinking about licensure or, have they done this work before? Do they want to do the work, and are they motivated by the right things? Because that can be really hard to change. So that was something we've learned over time that we've gotten much better at. And then task shifting, how do we work as a team to cross-train everyone to be able to do all the, generalist activities that are going to come up? So we have some team members that specialize on certain areas. We have, just as we have organizations that do. But overall, we've really tried to cross-train everyone so that you're not worried that so-and-so is out on vacation, so that there is redundancy. And it's not about licensure level either. Everyone, because we have a lot of depression in our population, we have a lot of suicidal ideation, and so everyone can do a suicide assessment. And that's something we've trained and protocolized, and everyone feels, no one ever feels comfortable doing it because you know, it's someone in a crisis moment, but they can do it and they have done it. So, and we've done that. We'll emphasize certain things if they're coming up a lot. And I know someone else mentioned that housing is another one that's been a huge barrier for us. We have one dedicated individual just to focus on that since it's such a huge barrier within our community. But we really do try to cross-train everyone and then emphasize. We started working with patients, a small number. I think we started with 25 as well. And we were doing the work, and it was crazy. We had no idea, you know, we did not train anyone. We just threw them in, and then people got burnout, and they didn't want to keep working with us. So we learned, you know, training is a really important part of the process. So we do a lot of mental health training. Whatever seems to be coming up, I'll try to find support. Child abuse training, we just had that. And then, you know, basic trainings to keep licensure requirements up. But that is not something we've always done, and now we really spend a lot of time because that's an important resource, and it helps people be able to debrief when they're doing really, really hard work. And then we fail fast. We try things all the time and we bomb them. Like this is a mantra in our organization. We try to innovate and be efficient, effective, but sometimes it just does not work, and it's okay. So we try something and it doesn't work, we change it. It's okay. And I think while we do try to step back and do some planning, when we started, we did not do that. It's not always, sometimes you just have to try it. Sometimes you cannot anticipate what's going to happen in the process. So we really do just say, you know what, let's try it. If it doesn't work, it's not a big deal. So really quickly, just in terms of relationships, what really solidified that concept for us, that the reason we knew we were effective was the relationship we were building with people. My colleague Maggie conducted a qualitative evaluation with some other community partners and interviewed our former patients, 25 of our former patients. And several themes came out of that work. So in qualitative research, it's coded, and then we have various levels of data. And then this led to the body. There's very little research on complex care, super utilizers, collaborations like this. So this was very important because we were able to understand, you know, what was it? Were we even successful? What was working? And how do we continue to build upon those resources? So this is what came out of it. We realized that there was an overall theme of authentic healing relationships. And that is really, when someone graduated from our program, that is really what drove them to that point in time. So these are some pictures that Maggie drew. She's very artistic to sort of sum up the idea. Oh, it was 30 interviews that were transcribed. And within that, we were able to see that motivation was a big theme. People felt motivated because we were genuine. We kept coming. Some people have called us stalkers, like, gosh, you always know where I am. And they felt secure in the process. And then we weren't necessarily always in the hospital. We would go into their homes, and wherever they felt comfortable, if the home's not a safe setting, we've built up locations within the community we can meet people. So that has been a plus. Sometimes it's people hate that. You know, they can feel very defensive, but overall, it really helped our ability to build those relationships. And we also learned that friend and family networks are essential. We have not focused on this enough, and this is a resource that came out of this research to show that we need to highlight this and continue to build upon these networks, because that's really how we're going to be able to keep someone out of the hospital in that long term. And friends or family, that could be the long-term team that we're always looking for, depending on that person's situation. So that is something that we learned that we need to do a better job of. So here are some of the quotes. She talked to me as a person, not as a patient. Just to have them come around and sit and talk is what I enjoyed, to know that they were interested in me. And they showed me how to bring myself back. So that has nothing to do with education around diabetes management or, they helped me get my driver's license. It really was listening and building that relationship and building that trust that distinguished us from the process. So I can't emphasize that enough as we're building out these collaborations and programs. So I also just wanted to focus on when we do plan things, we do a lot of Post-it notes, and we really try to involve all of the partners, whether it's my coworkers, all of the staff, and try to figure out what is really going to work and is everyone bought in. And this has been really, really useful for us. We've done it with board members, with our community organizations. What are we going to focus on as a group, and how do we move that forward? What's the process that we'll use? So when we took a step back and we wanted to focus on what are the things we actually do with people, we did come up with these domains, and we have 15 domains. And we have interventions built out under each domain. But that was the bucket. And it's not, most of it isn't related to medical care. A lot of it is social support, in referrals that we need to work to connect people to. And this is how we document it. As I said before, we're trying to find out what is that patient driver, what drives them, what are their overall goals for life. And it's often, I want to be able to go on a bike ride with my granddaughter. That's one that's come up recently. So we put those in, they're in the hospital, and we update them as these change, so that this is shared. This is an internal system shared with our team members. We do not have the ability to share this with community partners. I wish we could. So if you guys figure it out, I'm going to come back up here and you'll teach me. But that is not something we have a lot of expertise in at all. But we do have a system. All of our information is web-based. They don't use any paper. So, and this is HIPAA compliant. So in real time, everyone can get these updates, which has been really, really valuable. And then we have the domain. So if we identify a certain need or a goal, this will pop out, and we'll be able to just have a free text box that says what is the thing we're working on. Yep. And something that we've really used recently that I wanted to share with everyone to really build upon our collaborations within the community. I don't know if you guys ever have interns or people, they come in, they're there for a short time, and the resources are constantly changing. So you're like, I'll do a research binder, a resource binder. I'll update all the resources, but it's constantly changing. Funding streams change, people change. So what we've done is we're actually building out a website that will be shared to everyone who wants access within our community, frontline providers, patients, participants of other programs, and all of those domains will be included, and then all of the services and interventions we've built out. So it's a service similar to Yelp. I don't know if anyone's Yelped, but it's crowdsourcing. So if something changes in real time, someone can say, hey, that's not the phone number anymore, and we'll update it. So we're building this out to help leverage some of our learning, which we've had one person dedicated to building this out for 1 year. We were able to get that resource, and we're going to share it with our partners, because we see the social workers in the ED. They say, where are we going to send this person? So this has been really, really huge at helping people work with us, collaborate with us. Everyone is so excited for this to launch. We're going to launch this in a few months. And that has been hugely beneficial in getting people to join us in that conversation on what resources do exist and what doesn't exist. so that we can problem solve that as a community. So these are some of the detail that's been built out. So that's it for now. I don't know if you guys have any questions for me. I know we're running a little bit over, so yeah.
Secondly, how you navigate with other community providers. When you stumble across this and they already are involved with case managers or they already have services, and how your teams navigate that.
Yeah, so funding, it's almost all grant funding. We did have a Healthcare Innovation Award under CMS that is ending. It's in the process of ending. We're wrapping it up. And everything else is through grants. We are fortunate enough to have some people dedicated to that at our organization, but we do not bill Medicaid, and so this is a larger conversation we're actually having with the state. Recently, we've been able to get some of the care coordination money that the state provides the Medicaid managed care organizations to shift some of that to community-based resources. So out of that, we're hoping to get state dollars since we're the ones providing community-based resources within our community. But there are also other organizations, regional entities that are doing that in northern New Jersey, central New Jersey. So that's something that is coming up, and we're hoping will be a long-term revenue source. So, and just sorry, to answer the rest of your questions, we encounter other care coordinators all the time. I mentioned this yesterday. I don't know if you guys saw that article, Coordinating the Coordinators, in the New York Times, but it can be, it's not, we haven't had too many issues. One being because we're really focused on unconditional positive regard and authentic healing relationships. And I honestly, these programs, they're not concerned with that. They're really looking at very targeted metrics, and we have the flexibility to really take time and be much more open-ended. And we're not doing the same things. We're not going in and checking blood sugars. And if they have home health, or if they have visiting nurses or other care coordinators, once we find out, we try to collaborate, explain what we do, that we're not really overlapping. And usually it's of benefit not only to the patient, but to the various programs. And some people will say, okay, you have them. They're really hard. They don't even like me. And sometimes, we're giving them information that's useful, but usually those programs are even shorter term than ours. So a lot of times people will defer to us, and then we'll be sort of that, the person owning that relationship, as we talked about earlier. But we're constantly trying to find the long-term resource, and it's usually not the other care coordination programs, at least in our community, if that helps. Great. I know you had another question.
The funding of the grants, are they regional, national, what kind of grants?
We have all of the above. We have, regional grant funding. Our local 3 hospitals pay money into our health information exchange, which helps us get our person that triages the people every day. We have New Jersey-based grants for programs within New Jersey. Robert Wood Johnson is in New Jersey, so they have special initiatives just focused on local communities. And then, like I said, we just had a huge national award under CMS that has funded my team for the past 3 years. So, it's a little bit of everything. Yeah.
What do you call your ambassadors or your staff members?
Oh, they all have various titles. So our nurses are nurse care coordinators, and our community health workers are community health workers. And our AmeriCorps members are actually health coaches, and our social workers are social workers. So, and they all have very clear badges. And when we enroll someone, and this is a challenge, but also a benefit. It's not just one person. So we have to get someone to buy in. You're going to have a whole team working with you, and some people don't like that. But we, right from the beginning, we sort of show everyone. We have a booklet called the Passport to Health, where it has everybody's photos, and we're like, this is the team, and potentially everyone that you will encounter. And that's really helped the process, so that no one's confused as to why Jess is there and not Janine. So that's really been useful. Yeah.
That lady was talking on there, she was saying she was
We used to be employees of that hospital. We're not anymore. Yeah. Does that help? Okay. Yeah. Now that we're our own Medicaid ACO, we just became one in July. We've just changed the badges to represent. We have badges of all the local hospitals. So sometimes if we're getting resistance, it can help, but a lot of times it doesn't actually benefit us. Having our own badges is useful because people don't actually want to associate us with the hospital because they may have had bad experiences. So it just depends on the scenario, and we can kind of change that on the spot. So one more.
So I just want to focus on the 90-day part for a moment and have you talk about the stressors in that and whether you end up with repeats ever, and how do you deal with it when you can't find long-term supports for people who need it?
Yeah, so 90 days is just the average, coincidentally, and it's maintained that average. So it's not a hard stop. So that is how we help prevent anybody from being like, oh my God, there's still so much to do. As long as there's something to work towards, we will keep working with someone. Sometimes though, that process can stop. You know, the patient can start being like, I don't want to do any of this. It can, the relationship can fall flat. So if that happens, we really need to evaluate. So we'll use our backwards planning cards to redetermine goals. We'll have that conversation around the drivers saying, well, remember how you wanted to work towards this, what's going on? So people can change their mind about the program, and that's okay. But, you know, there's not a hard stop. So that's been useful. We'll work with someone. And sometimes it doesn't even last 90 days, you know. We just needed to help reconnect with, you know, transportation. So it just varies. And then we have seen people come back to the hospital who were graduates of our program. Right now, because of the way our evaluation under CMS is set up, we can't re-engage them. We will be able to come January. And we do have a re-engagement process that we use for people that didn't graduate for our program. So sometimes people move out of the city and then they come back. Sometimes we just lose contact with someone. Phone numbers change constantly, and we'll see that they're back in the hospital, so we'll re-engage them. So we do have a process put in place, and that's been really, really beneficial. But a lot of times people just say, I don't want the help, and we always say, if you change your mind, call us back. So we have flexibility to do that. So thank you so much.
So we have a break scheduled. Why don't we try to be back here about 10 minutes after the hour?
All right, so we are going to start with a video.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way. Do I have to keep...
I love that video. So apparently that that got sent around after the presentation yesterday, and Let's see. Am I connected this way too? Okay, great. So my name is Victoria. I oversee cross-site learning and workforce development at the Coalition, which is great because I'm a nurse by training, and before I was a nurse, I was a teacher. So I get to use both of those things every day. And what that translates for me is that I am the person at the Coalition that answers all of the calls about what our magic beans are. So we get a lot of calls, as you will, as you get into this work and you start to get some early success. And we're lucky enough to have Alone Net, who's our executive director, who has a national platform and a national stage. And so we basically get lots of calls that say, hey, tell me your exact process, tell me your secrets, tell me your workflow, tell me how you collect data, tell me what are the magic beans of what makes your program successful. So we get to answer all of those calls. And when I asked you what keeps you up at night, what I'm hearing is so much of what I identify with, which is this idea that you're in this ambiguous world. This is a totally new field. You live in ambiguity, and we want to hear, how do you get funded? What's the perfect tool? What's the perfect way to enroll people? What's the perfect process? What's the perfect way to communicate? What's the perfect tool that's going to increase my ability to collaborate with organizations? And I am here to tell you that there is no perfect tool. There's no magic beans. And the other big part of my job that's a really big privilege and that Kelly and I get to do is travel around the country, and we get to meet all the people that work on complex care that are really good at it. And these are our friends, and what I will say is that they all collect data differently. They all have different tools. They all work differently. They have different staffing metrics. Their workflows are all different. The thing that ties them together and why they're successful is that they do the work differently. The how is different than everybody else. And so what I want to talk to you today about is the how. And when I thought a lot about what you're asking, I want to know more about how do I make sure that my patient gets housed? How do I make sure that at the end of the day, I'm working with all these organizations? How do I make sure that we're working to get the perfect metric to capture, perfect care plan template to capture what we're looking for? You'll get there. Everybody in this room is a smart person. And as long as the how is effective, and I will tell you that is the single factor that ties together organizations that do this work and stay doing this work for a long time, it's the how, and it's all about relationships. And so today I'm going to ask you to kind of take off take yourselves out of the forest, or take yourselves out of the trees, and we're going to see the forest today. So I want to talk to you about test tubes, which is kind of our funny way of talking about underlying causes that go on in communication, underlying causes that kind of drive people's behavior. I'm going to talk about it from both a patient level and a systems level. And this was really an inspired theory that happened after we went to Aravind. So Aravind is an eye hospital in India. It's the largest eye hospital in the world. As a leadership team, we have the privilege of all traveling there. So we went to Aravind as a team to learn, because they are a model of operational excellence. They are the largest eye hospital in the world, started as an 11-bed hospital. Their profit margin is close to 10%, which in the States, hospitals are lucky if they have a 2% profit margin. They're incredibly profitable, and the unique thing about them is that 60% of their patients are non-paying. So they get that margin by being incredibly operationally efficient, right? So you go and you're expecting to see, and we did the same thing that all of you are doing. We're going to go, we all had our notebooks, we're ready to copy down the perfect template, the perfect system, exactly how they capture data. What do? I will tell you, they have the most simplistic data system that's on these boxy computers that you and I would laugh at. The whole thing is really very simplistic tools. The how is what is incredibly impressive. So they are all grounded in mission, all grounded in values. Every single one of their staff exudes values, right? So I'm the person at the Coalition that is really responsible for staff development and staff training, and I think a lot about values. And so I got the chance to sit down with the woman in India. Imagine this. So she's over 80 years old. I'm sitting next to her with coconut water. We're in the middle of India, and I'm like, this is the guru woman that's going to tell me how we figure out, how to train our staff. And she trains all of the Aravind staff. So I'm sitting with her, and I'm like, she's going to tell me the perfect answer. I'm going to get the perfect interview questions to find the people that can do the work. And so I said, how do you hire people? You must at this point have the perfect system for hiring people. And she said, no, she said, we don't have control over that. She said, we need such a high volume of people at this point. I can't possibly screen in, screen out like that. She said, we have basic questions that weed out the total outliers. But she said, I norm the behavior. And that was a big aha moment for me. So what she meant by that is, we say, the way we convey compassion and respect is, and she has actual protocols for exactly how you behave in certain situations. So I'll give you an example. The first one she gave me was, when somebody asks for directions, we physically take them and we don't point. And that's how we convey respect, because we're physically taking them. I was in the line at Wegmans, which is a grocery store in Jersey by us, and I noticed that all the cashiers had this acronym called GREET. And I always feel very cared for when I go to the Wegmans, when I go to the Wegmans grocery store. When I check out, they're very nice. They look you in the eye. They ask you how you're doing. And I always feel very cared for. And I noticed that they have an acronym about it. So they have actual concrete behaviors that convey that they care for you. And I always feel cared for. I don't know if they do or not, but I always feel cared for when I go through that line. So I started thinking, what are the behaviors that convey authentic healing relationships? How do we do that? And when I talk about, the people that last in this work, so when you think of these systems like NUCA Alaska, who's been held up by Don Berwick and CMS, they have remarkable outcomes. They've had them for decades. When you look at people like Lauren Hardin, who have been doing the work for a long time, that don't get burned out, that stay, that have remarkable outcomes, Corey Waller, when I name these people, it's about the how. The rest will come. The funding will come. The tools will come. If you do it the right way and you anchor in the how, everything else will follow. It's when you start to get lost in the tools and you make that about the process, that's when the whole thing will collapse. I will tell you that point blank. So it is the most important thing. We cannot expect our frontline staff to go out and be therapeutic with patients if we're driving towards outcomes and tools and metrics all the time. It is a total part of the process. It makes patient care better, but the bigger piece that people will notice, that community partners will notice, that patients will notice, is if the how is different. People will start to pick up on that, and it's the thing that allows us to coordinate and allows people to make exceptions for our outliers and all the organizations within our community, because they know people from the coalition are different. That's what you'll hear, and it is not easy to do in practice, I will tell you. This is our version of kind of starting to say, what are the behaviors that allow us to do the how? And they're collected from us, like I said, and also from our own experience, but also from all of these people across the world that we've visited that do this really well. So in our work, we've really found that there are kind of three main buckets that drive people's behavior. And I want you to look at these, and I'm going to give examples and stories about each one. But I want you to start thinking about it from a systems level, because as you start this work, you start to meet people from all across different systems. And if you think about it in this frame, it can be very effective to try to figure out how to break down communication barriers. So generally we find that people derive their behavior from really a deep sense of one of these, a longing from these three places. They want to feel important and recognized, a sense of love and belonging, and a sense of security. So if we start to think of people, and this is not a mechanism to bucket people in different buckets, it's really a way, because truthfully these test tubes change, sometimes based on the hour. Sometimes you can have multiple dominant test tubes in a day. Just trying to figure out in the moment when you're interacting with somebody, what's the dominant test tube? We call them test tubes because they produce explosions, which I'm going to talk about. So I'll get there. We have to get to know each other a little bit before we talk about that. So love and belonging. So when I think of love and belonging, I think of Carmen. Carmen was a patient that I would go and visit, and she always had the curtain drawn when we would drive up in the car, and she would wait for us, and she would have tea prepared, and she would change her tablecloths with the seasons. And when we would go in, she would want to just talk to us. She had so many issues medically going on, and all she wanted to do was talk to us about her childhood. She would bring out all her child albums. We would sit, we would talk to her, and she would have us there for a couple of hours just talking about memories. She had a daughter who loved her very much and was involved as much as she could be, but worked multiple jobs and had 3 kids, and so they had a life of their own, and she wasn't always able to go over and see mom. So all we did for that intervention, quite frankly, was go next door and ask her neighbor if she'd be willing to come over and say hi to Carmen once in a while. You know, say hi to Carmen, come over, see what she was doing in the mornings. Carmen's utilization and health outcomes dramatically improved just from that. I never, as a nurse, talked to her about diabetes, never talked to her about how to take medication. All I did was increase her sense of love and belonging, and that's what we did as a team, and that's what we focused on. I think a lot of times this also comes up with community partners. So if you think right now about all the organizations you're starting to think about that your patients touch, and that they, all of a sudden there's this new initiative that people want to be a part of, and it's the new jazzy thing that people are talking about. And I think organizations get love and belonging low too, and the people in those organizations can often get low in love and belonging and try to figure out, hey, there's this new thing going on that I want to be a part of. And so as an organization and as a team, it's your job to figure out how to figure this out with organizations and systems too. The deep desire to feel significant and recognized. When I think about this, I think about Javier. So he was a patient that I visited. He was in his mid-50s. I went and knocked on the door, and he said, I would never let you in, except I really like my primary care doctor, and she told me you were coming, and so just come in. And he and his wife sat in front of me and ate McDonald's, and I was there. Their diabetes was, his diabetes was uncontrolled, and so I thought it was like a big power statement that he sat there and ate McDonald's in front of me, and you can just tell like the whole time it was very much like it was done on purpose, I felt. So he had wrestling trophies throughout his whole living room. His whole living room was filled with wrestling trophies from high school. And again, he's in his mid-50s. He worked construction. He didn't want to take his insulin to his construction site because he was worried about what the guys at the construction site would think. He was worried he wasn't going to get as many hours if people thought he was sick. So he was very concerned about looking sick in front of other people. Kind of this, you know, and so this is kind of a characteristic of people who are in this test tube or who are low in this test tube is, you know, physical appearance tends to be a pretty big factor. He was, again, really, you know, kind of like a fit guy, really wanted to talk a lot about his glory days. So, again, the thing that we did with him was connect him with a local mentoring program where he could mentor high school wrestling students at a local high school. Again, for the first time in 5 years, started taking insulin. I never said, I need you to take insulin. His sense of meaning and importance in life increased and allowed him to start making changes that he needed to make. I think this is probably, as providers, the biggest one that we come across, and I'm going to talk about that a little bit later, but I think that what happens is we as providers who are new to this work end up having a deep desire to feel important and recognized because I will take the cat out of the bag. Nobody in this room knows what to do. I walk into patients still, nobody knows what to do. I meet with experts from across the country all the time in complex care. Nobody has a magic bullet. If they tell you they do, just walk away because they haven't been doing the work for a long time. The only way you know people are really in this is when you see them and they're like, this is hard. And you're like, yes, you're doing the work. You're my person. Nobody knows, right? This is a totally new field. So I think for us, this is a lot as providers, what our test tube ends up being. I think for organizations also who I think of academic medical centers are really low in significance a lot. They always want to feel important. They always want to feel recognized. A lot of times when you're coming in touch with or across organizations that maybe already do this work, so maybe, you know, home visiting nursing, for example, and I'm a nurse, so I can say this. Think, you know, a lot of times I would run into nurses in the field and they would say, well, I already do home visits. I already do med rec. I already do these things. And so it's a recognition that their sense of significance is something's happening, it's fluctuating for them, and it's our job as collaborators and communicators, good communicators, to say, you still have a place here. You still have a place here. I'm not taking your place. You still have a place here. I'm going to work alongside you, and I'm going to help to fill up whatever you're struggling to. And so you ask them, what's the part in your job you struggle with the most? Where are the gaps? Okay, so you can't go get the medication at the pharmacy. I can do that because my rules are more flexible than yours. I understand that. So it's starting to figure out, even when you're working with organizations, what's their test tube? What are the people's test tubes within those organizations? And how are you kind of maneuvering and you know, complementing and helping to fill up that test tube when it's lacking? The last one's security. So the desire to know what's coming next and to have controlled surroundings. Think about Margarita. She was a patient that we used to go visit. She was a medical anomaly. So this is a woman who was diagnosed with everything. I mean, her chart was like, you would just scroll and scroll and scroll, and it was just hundreds of notes. She had been to the hospital so many times. She was what they called in the hospital like a doctor house case. Like nobody knew kind of what was going on. When you would walk in this woman's house, it was immaculate. So like, I mean, you could always see fresh vacuum lines. And so I just think she was like always cleaning. And you would ask her to pull up certain medical records and she'd pull out these long files of filing cabinets, and it was organized by date and it had the specialist name. And so, you know, whenever we would talk about medical appointments with her, she would always want to know, who am I going to see? Who's the cab driver that's going to come get me? What cab company are you going to call? Who's the person from your team that's going to come? You know, a lot of questions, just anxiety around what's coming next and the desire to have controlled surroundings, right? I will tell you, we do this a lot as practitioners when we're living in ambiguity. Our first instinct is to start to say, give me something tangible. Give me a workflow. Give me a strategy. Give me, you know, a dashboard. Give me a template. And it's our way as human beings, I think, of making sense of chaos is to get the perfect metric, the perfect dashboard, the perfect thing. So I think we do this a lot too, and we're no different than, you know, patients are people. We're all people, but the hallmarks of this are kind of people who are asking a lot about next steps. And so when you're in meetings, again, and even among your teammates, when you're with organizations, when you're hearing those kinds of messages, it's a time to take a step back and say, what's going on? It seems like there's a lot going on in your world. What are you worried about? Because if you don't get to the root cause of it, a lot of times it comes out in other ways, and it'll be the person in the room that's like, but what's happening next? What's happening on Tuesday? What's happening in a month? And so, again, just another frame to start thinking about. So why do we care? Why do we talk about this? It's nice to kind of label this and name it, but why talk about it? And the way that we've started talking about it on our teams is through explosions. So the reason we call these test tubes is because they produce explosions. And I want to talk to you about my explosion story, about how it came up when I was a teacher, and then also how it came up when I started this job at the Coalition. So for me, significance is probably always going to be my main test tube. I think that's a theme for me, and it keeps coming up, so I'm starting to recognize that, you know, it's something that I definitely need to go back to. I would say the first time it came up in a really powerful way that was very pronounced was when I started teaching. So I graduated from college. I had a biology degree. I ended up joining a program called Teach for America, which is an AmeriCorps program. I went out to St. Louis and taught high school science for a couple of years. So I get out there, and what's going on, whenever I say it recently, I get really emotional because of everything that's happening there. When I see Ferguson on the news, we played them in sports. I was really close with a lot of the teachers in Ferguson. When they've shown news clips in St. Louis, a lot of those places are places I frequented and my students lived and I went to. So I go there and I show up, and you know, Teach for America is specifically for folks who aren't trained as traditional teachers. They give you what's called an emergency certification and put you in under-resourced schools. So the deal is you only get an emergency certification in teaching if nobody else that has a traditional teaching degree will fill that job. So the idea is that if anybody who had a teaching degree would fill that job, they would have taken it. I'm there because no one else wants that job. So it's under-resourced community. They put you in the schools that no one will go to. So I was working in a high school. When I got there, St. Louis had been through a pretty major redistricting. So they took kids from all over the city and started to even out attendance numbers. This is a really common strategy. Anybody who's familiar with education, we also do this a lot in healthcare. There's a lot of parallels. So they take kids and they even out the attendance numbers. So they start taking kids who used to go to the same neighborhood school and they start moving them all over the city. This produced pretty drastic, pretty violent, explosively violent situation with gang riots, race riots. We were in the middle of it. It was very common weekly for the whole SWAT team to show up at our school. I saw kids get maced. I saw kids beaten with bats. There were regular riots on a regular basis. And I taught chemistry in the middle of all of this. So on top of kind of all of the external stuff that was going on, I was, really young. I'm right out of college. I was teaching at a mostly black school, so I stood out like a sore thumb, the teachers included. I had never taught before. And it's really known to people in the community that Teach for America, you're not a real teacher. You're kind of somebody who's coming in. It's very much this, it's all of the things, right? So I'm this like savior person. I come in, I'm like supposed to help the people. It's all of the things that you would never want anyone to think about you. So I felt like I had this big target on my back. Teach for America is a very outcomes-driven organization, so it's a nonprofit that kind of runs like a Fortune 500 company, so you feel a lot of pressure. I hope you're all seeing parallels about how I hope this is all processing for you, so you're feeling tons of pressure, right, to succeed, and they're very outcomes-driven. So every week you have to turn in these trackers that have your kids' grades on them, and your boss looks at them, and it talks, you go kid by child, saying like, how's Sammy doing? Okay, he got this grade, what's going on with him? And so you go through this whole process, and I start teaching, and I give the initial assessment, and the kids, I find out I'm supposed to be teaching chemistry, and they're coming in with around a 4th grade level math skill. So I was like, okay, so I started working on basic math skills. Up to that point in my life, I would say I kind of was of the mindset that if you tried hard enough and you pulled out everything you knew how to do, things would work out. Like you'd find a solution. You could figure it out, and so I was kind of trained like, all right, if it doesn't work out, I'm gonna stay up later. I'm gonna read more books. I'm gonna, go to the people who know. I would travel. I went to Ferguson actually and visited a classroom of a teacher I really respected, watched that lesson, so you do the things you know how to do. So week after week after week after week, I'm getting the scores back, and they're bad. Like we're talking like regularly 50s, 60s. I had one week where I was like a 65, and I'm talking averages of classes, and I'm trying everything I know how to do. I'm coming to school and I am totally exhausted. So I'm walking in the door. I don't even have the emotional energy to deal with kids, right? Like I stayed up all night making these like lessons that I thought were amazing, and I'd show up and like we couldn't get through them. And so my significance test tube is really low. Really low. I'm craving the desire to feel important and recognized. On the other hand, my kids are also feeling it, right? So when I say kids, I mean my students. So my students are walking in every day, and they're bombing everything. So think about what that feels like week after week after week, to sit through class and to not, to be trying, right? To be trying and sit through class, and you're getting these scores back and they're bad every single week. Explosions happen when you're low in the same test tube as the person you're meeting. So whether that's a patient, a colleague, explosions happen when you're low in the same test tube because you can never give each other what you need. Just gonna pause there because I'm sure, I want that to think about that. And this still happens. So there's 2 options generally that people do when you're triggered in this way, when you're low and someone else is low. You either internalize it and get into a real shame situation where you're like, I'm not worthy, I'm really bad at this is, I'm not cut out for this, and you go into like this deep shame hole, or you blame. So I'm a blamer. We're going to watch a video later that Brene Brown, who's a social worker, and I'm also a wannabe social worker. So Brene Brown does a video where she talks about the fact that she's a blamer too. And I started blaming, right? Because it is so easy to raise your significance test tube when you make someone else feel bad. So I would go to happy hour and I would bash 16-year-old children. I would talk about their families, and I would talk about the values that their families had, and I would talk about their communities, and I would talk about other teachers, and I'd talk about how bad they were and how they didn't care, and I would talk about the community of St. Louis and how the bureaucracy, and I mean, we went through everybody. It was everybody else's fault, right? Because it was an immediate way to raise my own test tube. And what were my students doing, right? The same thing. So they would see me, and I remember bringing candy for a lesson, and they would say, did you get this candy from the white grocery store, right? And they're doing the same thing. They're doing the same thing. And I was horrified. I was like, oh my God, how do they, how can they do this? They're doing the same thing. It's the fastest way to raise your significance test tube is to put somebody else down. What do we do in medicine? We call patients non-compliant. We talk about how, it's the emergency room. And so we blame systems. We pit systems against each other. We do the exact same thing, right? So when I came onto this job in St. Louis, and fast forward, the interim kind of story is that during one of these riots, one of my students was stabbed. And I, as the rookie teacher, started getting tasked to go bring him his assignments in the hospital. So I kind of saw the dysfunction of the healthcare system and thought I could marry healthcare and education by becoming a nurse. So I did that. So I was not recruited by the coalition. I got my job at the coalition by stalking. I saw the Frontline episode and basically called everyone in the organization. Ended up getting that one of our old attorneys was also a former Teach for America teacher, so I reached out to her, basically begged her. I was like, I will do anything, I will shred paper, I have to be there. If they said no, I had full intention of showing up there, being like, I'm here. She said, no, we're hiring for a nurse, it's okay, come interview. So that's how I got my job at the coalition. And so it was my first job out of nursing school. So again, right? So I've already been through this. I went through this. I went to therapy. I did the whole thing. I did the worksheets. I did the evaluation. I did a lot of crying, self-reflection. And I'm in this new job, right? This is to prove the point that it still keeps coming up. Last week, I still had the same thing with an employee where I sat with them and had the same thing happen. So it's a constant battle and a constant thing that I have to keep presence with. So I'm here, I'm a nurse, it's my first job out of nursing school, and I get tasked to go see these really complex patients. And I was working in a different intervention than Kelly at the time. We had received a grant to do primary care transformation. So it was pretty vague and basically just said, I need you to go transform the way 2 primary care offices in the city treat patients with diabetes. And I was like, yeah, we'll do that. So there was a lot there, and I started to notice that I was really good at being with people when I just needed to be with them. But when the pressure of the outcomes started, which typically correlated with our grant reporting cycles, I would start to get real finger shaking, right? So I'd walk in and I'd say, Carlene, I gotta be honest, we don't have time for this. If you don't start taking your insulin, you're gonna lose your foot. You're gonna lose your foot. And then what would happen? Everybody's A1C would go right back up, right? Because then nobody, it was like the worst way to get people to do what you want them to do. But I think, so it started happening again, and I was able to recognize it this time a lot faster. Because teaching, it was into close to February before I started even understanding what was happening. So I think here I started to recognize it faster and started to say, I've got to learn on my own how to raise my own test tube, how to increase my own sense of internal validation to get out of the cycle. Because that's the only way to get out of it, is to start to learn mechanisms to raise your own test tube. So for me, a lot of times those are mantras in the moment, which is like, I'm smart and I'm doing the best that I can. And sometimes I have to repeat that to myself multiple times in my head when I'm going through a difficult situation. Like, I'm a smart person, I'm doing the best that I can. So you'll all come up with your own. That's gonna be part of what I ask. But for teaching, it was I had to stand in front of my kids and I had to say, this is really hard. And this is my first year doing this. And I'm sorry, because, I wish that I could get you somebody in this room who would know the right thing to do and exactly the right thing to do, but there's me. And so you and I are gonna have to work this out. And it was this really kind of vulnerable moment where I had to stand in front of them and say, I need you to tell me in real time if you're not getting what you need from me. And I'm gonna tell you the same thing. Because there was a lot of just, disciplinarily, we were out of control. Everything was kind of falling apart. And it wasn't until I did that we could get out of the cycle. It wasn't until I was just me, and I was not trying to be authoritative me, and I was not trying to be, loving me or teacher version of me. It wasn't until I was just me with them that we started to get out of the cycle. So I think when you're thinking about starting this work and what makes the difference, and when I think about systems like NUCA, so NUCA, for anybody who doesn't know, please research them. They're wonderful. They're a health system in Alaska that treats Alaska Natives. And I'll end with this point before you do the exercise. They've been stood up by CMS, Don Berwick. They have amazing health outcomes for their patients. And you go, and they have this conference called Connections. And you think you're going to go and get all these operational tools, which is what we all want, right? So everyone goes for the tools. And they spend 3 days with you and just share stories. And they say at the end of the time, it's all about relationship building. Because people in the community will start to notice, oh, those people are different. They're different. And they'll start to make exceptions. They'll start to work with you in ways that they haven't been able to work with other organizations because the how is different. If there was a tool to solve this problem in healthcare, we would have figured it out by now. Somebody would have, it's not a tool problem. It's that there's a massive communication problem, right? The best way to figure that out is to increase our own level of self-awareness. I believe that. So I'm going to ask you to share with each other. I'm going to ask you to share with each other. And what we're going to ask is that, how are we doing on time before I lost my... 20 minutes? Okay, so I'm going to ask you to share just with a partner. Each person is going to get 10 minutes, and you're going to share a time you had an emotional reaction to a patient. You're going to consider what were your test tubes at the time, what were the patient's test tubes, name one strategy you can use when coping with this feeling in the future, and here's kind of the key take home. What structures can you put in place to talk about test tubes on your team? So this is a really key factor. And a lot of times it's a quick line. Kelly's team has done an amazing job at transforming the culture on the front line. They start every day with a morning huddle. There's music, people dance. It's this way, but they have these quotes that kind of help to get out of this cycle. So one of the other sites we work with, the quote they came up with, "What's under your iceberg today?" And everyone on the team kind of knows that's a sign something's going on and I'm trying to ask you. So start figuring out those structures that might work on your teams and talk about them in pairs. So again, we'll do the music thing. I'll start playing the music, and when the song is done, we'll start coming back together again. Ideally, try to pick somebody who you don't get to work with all the time. So, okay, so 10 minutes a person. Just keep track of the time. It's a very good sign that people don't want to stop talking to each other. Makes me happy to see. So I want to ask you questions about feelings, frankly. So if you can name the feelings of how you felt sharing your experience with the other person, what were the feelings that came up when you were the sharer? Vulnerable. What else? Acknowledged.
Relieved.
Ooh, relieved. Validated. That means you had a good listener person, yeah. Validated, okay. Acknowledged and receiving. I'm repeating for the recording. Optimistic.
It felt good to talk about it. I feel like people don't talk about it that much. There's so much focus on actually delivering services, but not kind of strong actions.
So it was good to talk about it, and that people don't talk about it often enough, but it felt good to just get it out there.
I felt like I gained some perspective, that I might have been very focused on things that happened, but the other person can say, well, look at it this way, or just put a different spin on it.
Perspective gaining and taking too, right? So often I think we very much gloss over in healthcare that when we walk into a room and meet somebody, we have all of their information and we think we know everything about them, right? And that I'm asking you those questions to get you in the place where it's we remind ourselves how much we ask of people when they share their stories with us, and how vulnerable the feeling it is to do that, right? Every time I get up here and tell this story, I always have a moment where I think, God, I'm really, everyone is going to be judgmental, right? Even the feeling of feeling judged. Like, how much do I actually share of how bad I did? Do I share the happy hour story? Do I, how much do you go into? What are people going to think? These are all things that when we go enroll people, we go talk to them, all these same things are going through their mind. How much do I share? Do I share that when I go home, I actually don't take any of the medication they're telling me to take? Do I share that I actually eat McDonald's with my wife on the couch? Do I share that I don't go to the gym as much as they say? I'm not exercising. Do I share that I'm addicted to heroin? That is a big deal. And we forget that we're asking a lot of people. We also forget that we often go in with the mindset that we're there to sell somebody something in a way. Like we're there to sell the program. We're there to get people enrolled. And in actuality, what felt good to all of you and you were the sharer is just being able to share your story with somebody. And that's what made the connection. It wasn't that they were trying to offer you something. So just things to take note of. What did the other person do to make you feel, what behaviors did they do to make you feel validated and heard? Eye contact. Affirmation, what does that look like? Not like tracking you, nodding, All the active listening stuff that we all know. Active listening, not on the phone. There's no intake, right? They're not typing, they don't have a binder, yep. What else? Asked questions when they didn't understand something or they want to learn more information. Yep.
No, I felt comfortable.
You felt comfortable. Why?
Body language, understanding,
Body language, facial expressions. I will tell you very frankly. Yep.
Being able to relate to each other and share an experience.
Relate to each other and share an experience. I love that. I want you to hold on to that. We're going to talk a lot about that later. Okay. That's empathy, right? That's empathy. So I will tell you all of the things you just named, those are the magic beans. That is the magic bean. Those are all the magic beans to making your program successful and making it work, is to do that with every interaction you have with each other, with outside organizations, when you go and present. I think that the people in this room are, that are, we're the first followers, if you will, right? We're all the kind of people that are standing up after the first dancing guy. Everybody, because this is a really new field. So if you're in this room and you're interested in this work, you're kind of already a first follower. And I think first followers were often the rogue people of the healthcare organization, of the healthcare community. We're kind of rogue. We're the people that don't really like bureaucracy. We tend to not like, the healthcare system as a whole. And I think these behaviors are often easier for people like us to do with patients. They're much harder to do with CEOs and executive and C-suite level people. I will tell you, it has been one of the most profound and impact. It's had the biggest impact on me to start to think about, how do I have empathy with C-suite level people? How do I have empathy with CEOs? What does that look like? Because these are also the same behaviors that start to transform systems, is because when you can have empathy with up and down, people who are working above you, people who are working for you, our patients, it becomes very profound. And I think that's what allows programs to keep going. That's what prevents burnout. That's what allows us to see this as a marathon, not a sprint. I think this actually may have time. Oh, no, it didn't. So I want to end before you go to lunch and play this video. And it's 3 minutes, so you're not going to be too late. And it's kind of a funny way of norming, if many of you shared your stories with each other. It's kind of a way of norming that these are things that we all do. So after this is over, we can start lunch. Yep.
That you asked, and I think the way that teams can use this is really through supervision and reflective supervision, and I think that's a critical piece that many people are like, I don't have time, and building that, and I just want to say that before you moved on.
Yep, so we're going to actually start that conversation after we come back, so I have it I think I totally agree with you. It is, I say this very frankly to everybody in this room that's supervising people on the ground. I can't say this enough. We can't expect the people that we oversee to go out and be therapeutic with patients if we're not therapeutic with them. Too often, people come back after having to go see patients and be very therapeutic, be very empathic, and they're hearing stories that are incredibly difficult to take in, and then they go back to offices, and their managers are like, where's that intake form? How many people did you see today? What are hours? What did you track? And it is incredibly difficult to make that shift. And so as we're starting to think about setting up programs, it has been a huge lesson to us to start to think about the infrastructure to support those people, because they are the heart and soul of what's going to make your program work. So they have by far the hardest job in the whole organization. And I would encourage all of you to go out with them and to see what it's like. We just did, because we've gotten so big now, we just had our C-suite level folks go out and follow our frontline folks. And they had some pretty drastic revelations when they came back, like even everything from, I was really hungry and I had to go to the bathroom and there's no, and I can get up and go to lunch whenever I want and they're still seeing patients. And I was like, I really have to go to the bathroom and I'm hungry. And so I think even, really basic stuff. But when you're at this size, it's a lot easier to set up the infrastructures like that. As opposed to when you start to grow and they're not in place. So I think it's really crucial, really, really crucial to set them up now.
How many of you are blamers? How many of you, when something goes wrong, the first thing you want to know is whose fault it is? Hi, my name is Brene. I'm a blamer. Let me just tell you this quick story. So this is a couple years ago when I first realized the magnitude to which I blame. I'm in my house, I have on white slacks and a pink sweater set, and I'm drinking a cup of coffee in my kitchen. It's a full cup of coffee. I drop it on the tile floor. It goes into a million pieces, splashes up all over me. And a millisecond after it hit the floor, right out of my mouth is this: damn you, Steve. Who is my husband? Because let me tell you how fast this works for me. So Steve plays water polo with a group of friends. And the night before, he went to go play water polo. And I said, hey, make sure you come back at 10, because I can never fall asleep until you're home. And he got back like at 10:30. And so I went to bed a little bit later than I thought. Ergo, my second cup of coffee that I probably would not be having had he come home when we discussed. Therefore, and so the rest of that story is I'm cleaning up the kitchen. Steve calls, caller ID. I'm like, hey. He's like, hey, what's going on, babe? What's going on? So I'll tell you exactly what's going on. I'm cleaning up the coffee that spilled all, like dial tone. Because he knows. How many of you go to that place when something bad happens, the first thing you want to know is whose fault is it? I'd rather it be my fault than no one's fault. Because why? Why? Because it gives us some semblance of control. But here, if you enjoy blaming, this is where you should stick your fingers in your ear and do the na-na-na-na thing, because I'm getting ready to ruin it for you. Because here's what we know from the research. Blame is simply the discharging of discomfort and pain. It has an inverse relationship with accountability. Accountability, by definition, is a vulnerable process. It means me calling you and saying, hey, my feelings were really hurt about this, and talking. It's not blaming. Blaming is simply a way that we discharge anger. People who blame a lot seldom have the tenacity and grit to actually hold people accountable, because we expend all of our energy raging for 15 seconds and figuring out whose fault something is. And blaming is very corrosive in relationships, and it's one of the reasons we miss our opportunities for empathy. Because when something happens and we're hearing a story, we're not really listening. We're in the place where I was, making the connections as quickly as we can about whose fault something was.
Enjoy lunch. So we're going to start off with another video. It's a 3-minute clip. I love these just because I think they're good things also when you go back from things like this to kind of send around to your colleagues. I think it's just a fun thing to start to share.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So I think I said this earlier, I'm a wannabe social worker. That comes mostly from Kelly's influence on our teams. So I love her because Brene is also a social worker. Let's start here. So I actually would like to start, I just found this thing and I want to see. Nope. Okay. I would actually like to start, and I didn't get a chance to know your name, but you were the one that, Donna? Oh no, that's, you were the one that mentioned reflective supervision, and I was wondering if you wouldn't mind sharing a little bit about what it is. I don't think that people know.
So the way that we think about supervision where we work is a chance that people can come together. We do clinical supervision or different kinds of supervision. The model can be group or individual, and really having people have the time to bring up an issue or a family or someone they're working with, and have time to both think it through for themselves and reflect, as well as get input and support from another coworker.
So just to say another sentence or two about it, I think it's probably the most important tool for quality in our work and for preventing burnout. And Donna said the word reflecting. We use a reflecting team. We use a little bit of a formalized process to have an opportunity to have an individual be interviewed and talk about their work or some aspect of their work, and have a team be there to respond. And It for us grew out of a narrative approach, which I think we've sort of left a little bit, and but have kept the reflecting team. And I guess just one more sentence about it is that I've often felt like the human service reflecting team, human service focus on the importance of clinical supervision it's such a basic, important part of what keeps me able to do the work week after week, visiting sort of, hell at times. And I sometimes cock my head and wonder how people in education or in healthcare can do the work and not have the kind of supports that we built for ourselves.
I also want to say that I think, sorry, we'll just take this over. No, we're in human services, we do this a lot. But I think what's also important is we've created a structure where we have time every week to do this. And that's, obviously that's a commitment and a dedication. And when Mike spoke of burnout, which in human services fields where, pay is low and work is hard, we have a really low turnover. And I credit a lot of it to the importance of supervision.
So that is, thank you for commenting and letting me put you on the spot. I think that what we're talking about today, the focus is not supervision. I'm not going to explicitly talk about it, but I think in kind of the post-it notes of what you're taking home of things to look into, to maintain your programs. And again, when I think about size and where you are now, and thinking about how you scale on structures that allow your team to continue to do the work. So something to look into. I think everyone should touch base with these folks. I nerded out about reflective supervision for a while. So it actually started as a supervision model for early education, and grew into Nurse Family Partnership now uses it. And if you're interested in looking at other community-based models in your area, Nurse Family Partnership's been doing this kind of work for a long time. They actually dedicate a full hour a week to their supervisor and each person on their team, and also ACT teams as well. So just as a thing to keep in the back of your mind. And additionally, I think about this so much because I think that as we expand, it's something that comes up all the time in our work, is the idea that the people on the front lines are really the heart and soul of the intervention, and that we require and ask so much of them. And I think that there has to be an awareness about we as administrators, and I think I can say this because now I'm on the other side, and all of the tools that I'm talking about, and this afternoon is a lot about tips and tricks and a lot about tools, and a lot about specific behaviors, and it's less kind of abstract, and you're going to get some chance to practice that. But as I think about it, and as I think about what it takes to drive this work forward, and all the people that I've met along the way across the country, I think that they are all really good at supervising people, and they're all really good at building relationships, and that as administrators, and so to our folks on the ground, we also have to have empathy, same empathy for our administrators, because the systems they have to navigate within are often incredibly toxic, and when they come back, they often are dealing with similar emotions that you're dealing with on the ground. And so it's very easy for the whole thing to implode if you're not paying attention to all the emotions that are swirling around. So I'm going to talk this afternoon. I want to frame it for you a little bit. I'm going to talk about a lot of, like I said, that's much more concrete tools. And then in the second hour, so from 2 to 3, you're actually going to get to practice with standardized patients. So you're going to get to practice enrolling patients. We have standardized actors who are here for you that you get to actually practice with. And I think the key is not that any one of these tools is the way to go. It's the idea that you're building a toolkit, and so you get to use them at your disposal. You can pick, this is appropriate to do now, this isn't appropriate to do now. It's just the idea that as we go through the afternoon, you're adding more things to your tool belt. The most important thing to remember through all of this is that the skills that you use to enroll people are the same skills that you use to listen to each other. And so when you sit down with somebody, it's just another normal person, and you're asking to hear their story. And as long as you sit and keep that frame, we often find that when people call us as an organization and say, we can't get anyone to consent, it's always a culture problem. I've never run into it. It's always a connection problem. Because when people connect with you, then it's really not about, it's not about the service. It just becomes you're another person, and as long, and it typically doesn't result in any issue in enrollment. So I'm going to talk about really concrete stuff. Feel free to raise your hand. The first one is specifically about the Camden cards. You can stop me. So coach is, I'm going to put this on my shirt so I don't. Coach is the philosophy that I developed when we came back from India. And it is the philosophy that I talked about norming the specific behaviors. So we're not going to go over all of these today. What you heard me talk about in the morning is the Connect test with vision. So those are the test tubes. And basically talking about what is somebody's vision for their life. That's the test tubes, right? So their vision is to have a sense of love and belonging, have a sense of significance, have a sense of certainty and safety. And then the tasks that we talk to them about fit into that. So housing often fits into increasing somebody's sense of certainty and safety. Reconnecting with family often fits into somebody's sense of love and belonging. I'm going to talk to you about O this afternoon, and the second C, which is check backwards plan. These, they're not meant to go in sequence. It's just tenets of good care. But all of this is pretty available online. We're still working on H. It is actively in development now, so we're not really always done with the philosophy. I love this quote because this is how I love to think about all of patient care, taking people from where they are to where they want to be. The first one, so Laurel talked about the Camden cards in the morning, and this is them. So it is, we call it backwards planning, and it's a game board, really. All of what I'm about to show you went through pretty extensive iterations with our frontline teams. So they've had control and input into how big the letters are, the phrasing that we used, and it's all based on experience with their patients. The one thing, this is all printable and it's all available to you in soft copy. They've told us that it's much easier to print out in cardstock. They found that the paper would blow away if they were outside, or that it would rip. So some folks have even said they wanted to get it laminated, so just something to keep in mind. Basically, they're cards of the care planning domains that Kelly showed you earlier. So this is the board, and patients have an option to put the cards in one of these 4 quadrants. So we explain to them, we say, here are all the 12 cards. These are all the things that we can do for you. And it's like housing, and I'll show you the cards in a second. And then they say, I need to work on it now. I don't need to work on it now. I need to work on it, but later, or I don't need to work on it later. They have the options of where to put the cards. So these are what the cards look like. We took the care planning domains, and our frontline teams, again, had input into patient-friendly language. So they're all patient-friendly language, and they're vetted for our specific population. So as Laurel mentioned, they decided to put pictures. You might decide you need different phrasing. They need to be changed in some way. You'll probably have to go through the same iterative process with your patient population. But have support, talk to someone about my mental health, get a job, or go back to work. And then our frontline teams came back and said sometimes people still are struggling with what that is, and so we give ideas about it on the back so they can turn it over, socialize with my friends and family, find a good friend, feel like my life matters to someone else. And so these are kind of all examples of what things go on the back. Feel better about myself, have more energy and motivation, have fun and not worry all the time, get an education, work hard at a job I like. So they're placing these cards on that board that we showed you. This is what it looks like in real life. So for our care teams, as Kelly mentioned, and I don't want anyone to get freaked out by this because this took us 10 years, so just put that in context. These housing and support provider relationship correlate with our care planning domains, and so now we're almost at the point where our care teams will be able to see that and have a protocol for what to do based on, and specific community resources that go along with those things. Again, that took us a really long time to build, so you're not going to be there yet, and that's okay. So have transportation, have a better living situation, help people in my community, have a better relationship with my doctors and nurses, get a job or go back to work. So based on where they place this, it's an option to start a conversation. And this is kind of how we think about it. So the first thing we like to do is pick up the highlight strengths card. So a lot of times people say, well, why do you even bother having people put cards in the box that says they don't need to work on it ever? And really it's because it's a place where usually things are going well for them. So sometimes people only have transportation in that box. And you pick it up and you say, tell me more about this. How did that work for you? How did you develop that system? It's an option for you to start a conversation. Oftentimes these two diagonal quadrants, this is where things get interesting, because a lot of times patients put things that we as providers would say are glaring issues that need to be addressed, like, you know, maybe they put something like addiction, and that's a big deal that keeps them coming back to the hospital, but they don't think it's their priority. Maybe they say their priority is housing, or it's food, or it's clothing, and that's okay. So as long our philosophy is very grounded, and as long as a patient or a person wants to work on something with us, we work on that thing with them. And then because it's really all driven by that person. So the other cards, it allows for a conversation to start. So it is that's where we prompt our staff to start asking open-ended questions. So I noticed that you put that you wanted to work on addiction, and you don't feel like it's a priority right now. You feel like these other things are a priority. Tell me about the board. Tell me why you chose to put those as a priority. And it starts a conversation. We don't use this all the time. We don't mandate that our staff do this all the time. It's not a protocol. It's just an option if people get stuck. A lot of our staff come back and say, it's helpful in two main scenarios. One is if they're sitting with a patient and they're just not getting anywhere with them in enrollment. It really kind of helps. They can bring out the cards, and it helps to start to have something tangible for people to move and put around. The other time is they say sometimes they're a month into the intervention, and all of a sudden progress just stops. And so it's an option for them again to bring out the board and say, hey, our priorities must have changed. Tell me, let's go back to the cards, because in the beginning you said you wanted to work on this, but now it seems like things may have changed. Let's go back to the cards and start talking about this. So it's just a tool, again, that you have in your tool belt. You can choose to use it when you want. I want to emphasize that it's not a protocol. We don't use it every time with every patient. Do folks have questions about that part?
Vermont Recovery Network is a similar tool, but it's not a board game. It's called the self-sufficiency matrix. And what it is the coach would sit down with the person that they're coaching, and they would, together, they would fill out somewhat the same thing all the way up to the crisis level. And the person would just circle where they fit on this, and that's where the talking points would start with the coach between this person. And and it also gives them then you grade it over the time period that you see them, like once a month, where these things have changed, the number has changed too. And all the 12 centers in Vermont use this as a recovery coaching tool. And it's filled out every 3 weeks. It's filled out every month. So that both you and the person can see the changes. There's no name or anything put on it. It's just identifiers so that we know who it is. And so it doesn't have a HIPAA issue. And it's similar to what you're doing here, but it's on a card. I mean, it's not on a card.
Did everybody hear that? So the self-sufficiency matrix, this actually came up yesterday. And the other caveat I want to say to this is if it's not broke, don't fix it. I'm off, if that works for you, then cool. I'm not advocating to change the cards. But I think it is, if that works, then it definitely seems like it's a tool that the other sites also mentioned. So I think it sounds great. I've never seen it in person, but I'm definitely going to look it up afterwards. Will you give me that one? Cool. Look at that. plain material? Okay, so the next piece is O, which comes out of coach. It's called observe normal routine. Gosh, this has been our life for the last year. So it's really interesting. If you look back on Jeff Brenner, our executive director, he has tons of videos on YouTube of talks that he gives. The framing of our intervention used to be like a SWAT team. We used to describe our intervention like a SWAT team, like a team of people that would go in and fix people and fix things. And we would just go in and invade your life and fix things. And that was very much how our care teams operated. It was very task-oriented. It was very, they had checklists. They were focused. They were gonna, they were gonna drag you across the finish line whether you wanted to get there or not. And they took, I think that was very much a source of identity for a lot of our staff members. They were very proud of that. They would say, we get people to do things, we will drag them, we will do whatever. We have had a total mindset shift among our staff, and we've led our staff through the journey. For the last year, in all of Coach, we've only focused on this letter that I'm about to talk about, which is O. And it's really changed a lot about our culture. So I want to say that so that you all know that I'm not standing up here like we have this perfect staff that always does these perfect things. It's really hard. It is hard. It takes a lot of supervision. Kelly is I would put you in like management guru material. She's amazing to watch because you're just really good at managing people. So before taking any next steps with a patient and managers in the room and people who are administrators, I also love this as a management tool, ask questions to find out their normal routine. This is such a simple idea, but because we're all going to laugh when we talk about it. So this is a scenario. One of your patients is a diabetic who also is an amputee. She needs to arrange transportation to get to one of her appointments, and you notice she also has Medicaid. The appropriate next step is so our teams were living in the worlds of A and C, so they would either give cab vouchers directly or pull out Logisticare information from their bags and give it to the patient. What we realized is this was great during the period of the intervention, but when the intervention would end, nobody knew how to do this on their own. So we have totally had to have an entire, when I say focus, like this has been their lives, and the emphasis on this has been huge from a management level. Ask, how do you normally get to appointments? We intervened in so many situations where people had stuff that's already set up. Like maybe they have a daughter that already takes them to appointments and it works and they don't need to revamp their transportation. Maybe that's one thing you don't need to worry about. There are a lot of things people do that might be a little quirky and a little out of the box, but it works for them. And so the idea is leave it be. Like if it's working for them, we leave it be. So how do you normally get to appointments? This is a situation that actually happened to me. So Bernard calls and he says, after he takes his insulin out of the fridge, and he says to me, the name of the insulin, he describes that it's usually clear, but now he sees little floaty things in it. This is the part where it gets really hard. I'm a nurse. I can totally answer this question. In fact, I went to school and I paid a good amount of money that I'm still paying off in debts to answer this question, right? I would love to answer this question for Bernard. It's ultimately not helpful, though, for Bernard, for me to answer this question, because I'm not going to be there in a few short months, and then he's going to have to figure this out on his own. So, who would you call if I didn't pick up the phone? What I discovered with him is that he actually had a pharmacy, so what he told me is there's a pharmacy down the street, and I could probably walk with the bottle and go talk to them. Before Bernard got to the pharmacy, I was able to call and say, hi, we've been working with Bernard. Would you mind us serving as a long-term resource if he has questions about his medication in the future? And they said, no, that'd be great. He was a patient of ours, that's great. Bernard still goes to that pharmacy years after the intervention that I did with him is over. It's a long-term resource, it's always gonna be there for him. It's much more effective strategy than him having concierge access to an entire team of medical people that answer any question at a whim. Not only that, the deeper point of this is what it's really saying to Bernard is, I respect your dignity, I respect you as a person, and I respect that you can figure this out. I do not stand here as an expert in front of you. I actually think you're probably better suited to figure out these things than I am in your life. And so
This takes a massive identity shift on the part of medical providers, because often what we put our weight on is our ability to answer questions for people. And this was a really hard thing. We lost some staff over this because they just couldn't get out of the identity shift when we first started. And I think this is really hard because people see their license as, you know, the weight of their license is really being able to educate people. And from, you know, my experience, and I think what I've read in the literature, and we can back up, is that education's not the problem. The majority of people that I met with on the ground knew exactly what medication they should be taking. They could have educated any basic nursing student on most of the things that they were doing. They just weren't doing it for some reason or another, which I believe to be test tubes and those underlying factors. Education almost never fixed the problem. I'm not advocating that Bernard doesn't need to know what his insulin looks like. I'm saying that I am not the best person in the medical community to give that answer if I'm only a short-term resource. So it's much better for him to reach out to people who are going to be long-standing supports in his life, like the pharmacist that's down the street, like his primary care provider. So sometimes my life as a nurse in the field looked like sitting with people and saying, geez, you lost your appointment to the cardiologist. This is likely to happen in your life again. We all lose things. You don't have access to Google, so it's not helpful if I Google the number for you. Who could we call? Oh, well, my neighbor down the street goes to the same cardiologist. She goes to the same office. Okay, let's walk to her. And that's often what this work is. It's co-problem solving. It's partnering with people and figuring out what's going to work for them in their life. I want to show a video of Mark, who's one of our health coaches, and he actually talks about his use of O.
Yourself. My name is Mark Morales. I've been serving as a health coach on the community health team here at the Camden Coalition for the past year.
Great. Do you mind sharing a time that you did not observe a normal routine and instead tried to solve some of your patients' issues directly?
Sure. I was working with an elderly couple who are actually both patients on our panel, and one of the difficulties that they faced is that they couldn't keep track of their medical appointments and they didn't have transportation to those appointments. They really relied heavily on their daughter to do both of those tasks for them, but unfortunately the daughter worked full time and sometimes they just didn't make it to appointments. So I kind of stepped in, thinking to myself, okay, let me arrange some kind of outside transportation for them and kind of teach them a way to keep track of appointments for themselves so they don't have to rely so heavily on their daughter. So I connected them to Access Link, which is a public transit service offered in New Jersey. And I also kind of came up with this fancy planner where they could keep track of appointments. But unfortunately, neither thing really worked. The couple, I set up an assessment interview with Access Link. The couple never attended. They weren't interested. I gave them this fancy appointment calendar sheet. They never used it. And then we kind of had this conversation afterwards, like, what's going on here? Why aren't you utilizing this? And they said, we've been relying on our daughter for years and years to make our appointments and to take us to the appointments. And that's what we're going to continue to do in the future. And it was at that point where it really hit me, like, this is their normal routine, and I need to build from the normal routine rather than kind of trying to impose my own system that the patients aren't going to use anyway.
That's great. So in contrast, what about a time that you did observe a normal routine, and hopefully you can touch on why that had a bigger impact?
Sure. So this past winter I was working with a really challenging patient who was in her early 30s and had a brain tumor and lost a lot of her cognitive ability and her memory because of the tumor. So she had difficulty remembering to take her medications and also remembering when she scheduled doctor's appointments. She was seeing a number of different specialists, so it was really overwhelming for her. And when we kind of stepped in, the first thing we did was kind of observe what was effective, like what was she doing effectively. And we noticed that she told us that every day to remember to pick up her kids from school, she would set an alarm on her cell phone. So, we noticed that was a part of her normal routine, so we decided to then incorporate that from a healthcare standpoint, and we had her set a cell phone alarm for her taking her medication in the morning as well, and that proved to be really effective. Another thing that we noticed that she was good at was going back through her voicemail, listening to voicemail, and then taking down information. It was great because if it went too fast, she could just replay the message over and over again until she had all the essential information. So based on that observation of her kind of normal routine of information gathering, we encouraged her, after she made an appointment with the provider, to then have them just give her a call and leave all the information once again on her voicemail. That way, if she missed something important when the provider, over the phone was giving her appointment information, she could just go back into her voicemail. She knew how to do that. She knew all the information would be there, and she could keep listening to it over and over again until she got all the information. So these were things that were easy for her to incorporate because they were kind of already part of her normal routine, and just applied in this case to her care, her health care. So that proved to be an effective intervention.
So Mark is starting medical school this week, so he went on, and I just think it's an interesting spin on hearing him from that level. So I'm going to ask you to do this exercise in a second. What I want to say is that the implications of O are not just with patients. So to the administrators that are in the room, this also, I think, is really important when working and managing people. There's a classroom management book that I kind of fell in love with called Teaching with Love and Logic. It's also a parenting book. I'm not sure they're much different. I think they just replaced the word teacher with parent and sold another book. But I think I'm being recorded. That's not a good idea. But it really does talk about, it talks about basically this philosophy in a classroom management strategy and a parent strategy, which is really before starting to shoot advice off at people, which is what we're all trained to do, to really sit back and say, oh, what are you thinking about that? How are you planning a problem solve about that? The times when I have been most hurtful as a provider and as a manager is when I start to get into talking mode. When I start to walk up to people and say, yeah, so, we're going into this meeting, and then afterwards I need you to do the minutes, and then, and start kind of spewing off advice, when in actuality, they probably would have done that if I had just said, hey, so we're walking into this meeting, what are you thinking of, how are you thinking of handling it? What's your strategy? Rather than barking at them before we walk in the meeting, stressing people out, and then sitting in the meeting and having everyone be on edge. It is so often that we're really proud about the knowledge that we have and about our titles and our licenses. And at least in my experience, what I've come to understand and what Kelly showed earlier about these authentic healing relationships is that nobody remembers that stuff. People really remember when you're a co-partner and co-problem solver and helping to figure things out with them. So I think this is the last exercise we're going to do before you work with your standardized patients. And I want to frame this because when you start to work with practicing to enroll people, all of the stuff that we talked about today is going to come up because it's ambiguous and it's not something, we've done before. And so you're going to say, some of you, might, like if you're like me and you're a blamer, you might say, I didn't get enough instruction. There's no protocol. Where's the script? There are no things. We didn't get enough instruction. Some people might start to say, man, I'm really not good at this. I really hope they don't call on me. This is really embarrassing. Everyone's going to be judgmental. They're going to there's always that find out. They're going to find out that I'm really not supposed to be here. I always had that when we were looking through people at the coalition because I'm humbled to work next to all of these amazing people every day. I'd always be like, one day the HR is going to find my resume and be like, who is this person? How did they get in there? So I think that it's, be aware that all that stuff is going to come up. So I'm prepping you that as you're even in the middle of the patient interaction, the practice interaction, it's going to come up. And you have all the tools you need to do this. It's talking to people and it's being kind, genuine, and human people. So you have all the tools you need. This exercise is really going to prime you for that. So what I'm going to ask you to do is share something that you're looking to currently change in your life. So I don't want you to share something that's so vulnerable that you're going to go into a shame hole about it. So I don't want you to leave here and think you shared too much. Usually in other times that we've done this, people share about wanting to exercise more, wanting to cut back on the amount of caffeine they drink, wanting to cut back on the amount of chocolate they have a day, things like this. Not, again, not shame hole stuff. And the responder is only allowed to ask open-ended questions. So it's kind of like an Italian sitting with their hands when they're talking. That's what it reminds me of. So you're not allowed to offer advice. So when people are talking to you, you're just allowed to ask questions. And think about Brene Brown's video. And how do you get to the place of Me Too? Like, how do you get to the place where you're sitting with someone who's going through something really hard, and you can, with your body language and by being there with them and really feeling what they're feeling, get to the place of, I get it, and it's not easy, but I'll go through this with you, and we can do this, and I'm going to be here with you. After the exercise, I want you to talk about what emotions came up for you when sharing and responding. I am not going to ask you to share what you're trying to work on out loud. I'll just ask you to share the reflection, so that can be personal between you and your partner. Try to pick somebody that you didn't share with earlier. And we're going to do, so it's 40. I'm going to ask that you do 7 minutes a person, and I'll prompt you. So 7 minutes a person. Try to pick a partner that you didn't pick earlier. I'm the person that's always late to meetings because I get stopped in the hallway by somebody and I can never cut them off. I get it. So we have a couple minutes till we start with, it seems like this is not. We have a couple minutes till we start with the standardized actors. So I just want to ask again, as a sharer, so when you were sharing the thing that you were looking to change, what feelings came up for you? Vulnerability again. That was said earlier. Good. Yep. Denial. Who said that? That's very brave. Good for you. What else? What was it? Hopelessness. Frustration. Fear. Feeling like you're not a worthy person. Also very brave to share. So you as the sharer are getting more insight about your own situation by sharing it out loud. Is that what you mean? And really having someone listen. It moved you maybe a little further along the path just by talking out loud. Now, she didn't give any advice, right? Okay. Go into confession. So, you feel grateful. I very much also get that from my Italian background, yeah. Which, yeah. Yeah, go ahead. You felt appreciative of her? Okay.
Well, and the question encouraged me to okay. I felt surprised at what I was able to share or just meeting someone and say, here you go.
Isn't that weird? And it was only 7 minutes.
Yeah.
Don't you feel like you shared so much in 7 minutes?
I shared something that was not incredibly personal, but it had something that, I have carried with me for, a few years. And it was just like, okay, can you help me fix this? Or this is really more in my mind than I think it has been.
It's amazing. I totally get that because I've done exercise myself and felt very similarly.
I was put at ease when she said, well, yeah, that's my issue too.
That was the Me Too, right? Yeah. That's Brene Brown's, that's empathy. That's Me Too.
What the last couple of people said, and that it was a pleasant and positive experience after you got through the initial vulnerability, that someone wanted to sit and listen to your problem and help you solve it.
Did anybody have the feeling like, I am going to share this problem, and then I'm going to discharge it onto you because I would like you to now solve it because it's really hard. Did anybody have that feeling? You had the opposite feeling.
And I know that's myself, not the person who I was working with, but like I could feel myself not really being open to solving the problem.
And did the person stick to asking open-ended questions? Yes. So we all have resistance, right, when we're looking at our own problems. And I can guarantee if that person had come back and started giving advice, you would have shut down and stopped talking, right? Because it's, there was somebody, where are you, really good back here, who said, I am really going to stop and I'm going to try. Do you mind if I share what you said? Because it was so beautiful. You said, I'm really going to try to stick to this not sharing advice, because if I wasn't, I would say. I would say, which is so beautiful. Like, it was such a great, I would say, I think you really need to call this person. But it was so great because it's so, I get that. I so get that. It was so great. So I'm going to read you your patient scenario of the person that you're about to meet. And when I'm reading it, I want you to start listening for the nail, right? Because there's going to be a nail. So what I'm going to tell you is likely to happen is that you're going to start reading this, and it's likely that you're going to walk out of this room and then your clinical hat or your administrative hat or your good analytical hat, which we all have because we're all smart people that like this kind of work and like problem solving, you're going to walk out and you're going to say, oh, so you're having stomach pain. Does it get worse with food? Do you? And the whole interaction is very easy to become about clinical diagnosing, right? So I'm just going to caution you that it's so easy when you walk out of this room to because this is all new. So to totally put on that other hat, and it's ambiguous. And what do we do when things are ambiguous? We like to go back to what's comfortable, right? So I'm going to ask again that you kind of go out on a limb. So I'm going to read this, and you should start thinking about the nail that's in here and what things are likely to get you down a very tunneled path of distraction. So you're going to meet with, this is a patient who's coming to meet with you about his chronic care. He has diabetes. His name is Jim. He's a 45 to 55-year-old man, you're not sure, who's legally blind due to diabetes. He's divorced, and he has 2 children that are in his custody. They're boys. They're 10 and 12. You're going to get this again when you go in, so I'm just giving you a brief overview. Don't feel like you have to write down. He's on his second marriage. And he's there to talk to you about transportation. So the key is that you have to figure out his story, and you have to figure out what's going on with him as a human. So you might leave and have no idea what medications he's on, and you might leave and have no idea what his symptoms are, and that's all okay. What are his goals? What's his story? What are his goals? What's his story? So he might come in saying he's there for one thing. What are his goals? What's his story? That's it. And when you go to meet real people, what are their goals? What's their story? So you're going to do this for 45 minutes. I'm going to hand the mic over to these folks, and we are going to do this for 45 minutes, and then you're going to talk in your small groups for the last 30 minutes about kind of tangible action steps that you're going to take home from today.
Thanks. Just a brief note about how this will work. We are dividing you by communities, so I'm going to read off the community, the breakout room where we'd like you to go next, and each community will have one of us facilitators with you in there and the standardized patient to help you with this exercise. Once we get there, we'll explain a few more details about how to do it. So for now, we'd like you to go to your breakout rooms. Central Vermont goes to Kingsland. Laurel is your facilitator, and Bob is your standardized patient. And the people at the door can help you find your room. Middlebury will go to the Diamond Ballroom. Right here. I knew that. You have me, and we have Ralph as our patient. Morrisville, you're in the Willsboro room. Your facilitator is Patty Lahner here, and your standardized patient is Kenny. And St. Albans, you're going to Valcor. Your facilitator is Robin, to my right, and your standardized patient is Randy. So we'll see you in your breakout rooms.
All right, everybody, welcome back. We're gonna close down this day. So I'm gonna go around to each community, and if you guys could designate someone, or if we could have another volunteer. I know a lot of you just volunteered and made yourselves really vulnerable. If I could get a volunteer to talk about what that experience was like, some of the takeaways, and then what your next steps in your communities might be. If you got there, that would be really great. So I don't know if a community wanted to start first on what that experience was like, how it went. Well, I'm going to call on someone. I'm going to do it. All right. Come on down.
What did you want us to tell you what it was like?
What it was like, and then if you could talk about what your next steps as a community will be.
Do I have to scream loud enough? That's not what my kids say. A good clap to everybody who volunteered to do this. I know Meredith was our first one, so she was like under gun and did a really great job, and then got the Candom sheets and was like, here. And she's like, yeah. And Jim was really funny. He's like, what are these? And I'm like, she probably doesn't know what they are either, because she hasn't even looked at them. We just learned about them. So I'm sure people had similar situations. But I think it was interesting. I think we took different, she kind of got through to give me, because I was number 2 going up, where we were able to delve into the bullying on the bus and trying to hook up Jim with the school and connecting that way. And then Rory, the third one, went in and kind of realized it was going the same way and gave herself a timeout and said, wait a minute, I'm just playing this last 2 scenarios, and kind of fed into one of Jim's openings about nutrition and took it a totally different way. So it was really interesting, because we're all bringing from different practices, disciplines, nursing homes, home health, and experiences that we all got to learn something. Where we're moving forward is we all realize we don't know when our next meeting is to have this meeting. So that's going to be the first thing we're going to figure out when we get back to our county. And then we were going to pluck and choose and steal wheels that have already been created from other counties on waivers, on these Camden cards, and try to not reinvent anything and just borrow and share and try to do the same stuff everybody's doing. And we wanted to, we talked about we worked at one point in our meetings, and I got to be honest, I don't know if it's the community health team, or if it was the functional health team, or if it was the executive health team, or the UCC, or the ERCP, or the ECHO, because they've changed. I don't know which one, and I don't know what the name of this one's really going to be. But we've talked about how we did talk about, we really, at the end of one of those meetings, we would talk about unidentified patients that needed help. And it's hard, especially in our little county, or our county and your counties, you're probably seeing that half the people at the table know exactly who you're talking about because they've been touched and it's a small county. So that might work really well in Camden, New Jersey, but we seem to know everybody around here and everybody knows everything. But I think the importance of being able to get a waiver and share all this information, that's one of the biggest things. I've got a hospital across a helicopter field, I've got a doctor's office across the street, I've got the Manor Nursing Home right over there. And we're all not talking the same language, even though we're all playing the same game. So we really have to work on helping these people in our community, and yours in your community, and how are we going to do this. So I think this is a good movement, and I think maybe we'll make it happen this time. Somebody said it really good earlier. Let's make it happen and not just talk about it. Was that good?
Thank you for being the first. All right, who wants to share next?
Hi, I'm Mary from Washington County. We had our wonderful Jim, who was actually Bob, and some really skilled folks that got up. And I think the most ringing piece for us was that people worked on developing a relationship and listened. I thought we viewed a lot of empathy that was provided not just in the way we spoke with Jim, or our role players did, but also in body language. And Jim gave us some really good feedback. The group engaged through the process, which worked out very well, and asked questions. And all in all, I think we were very proud of our group that went out there and put themselves on the line. So just really learning to listen, being concerned about the family, what was going on in the family, watching Jim's body language actually as he was talking about that. I think that our role players picked up on that, delved a little bit, and we used our Camden cards. So I think Kenneth did a really fine job of picking those up and beginning to incorporate those into the process. And so there was some nice partnering that went on between the two. So that went well. We have a group that gathers in Central Vermont, so we call ourselves the Community Alliance of Health Excellence. CAH. Say it, CAH. Or CAH. We have done one pilot with a small group of providers coming around the table, identifying some folks that have some chronic care issues. We've completed that pilot, so we're actually looking at another panel right now of people, and what we want to do is take what we're learning here today, and we're going to go forward, set a time to talk and how we come together as a system outside of our individual systems. I think we all recognize time is one of our major hurdles in coming together. So the goal to come together with Nancy, our facilitator, is twice a month. And so we need to talk about whether we can do that and how we do that and who would be at the table. But we have some leadership through our community health team that communicates with everybody. And so we work through them, and with myself from mental health, Patrick Clark and I will come together to try to kind of plan an agenda going forward for that group to come together to embed the learning collaborative principles over the next pilot of moderate risk individuals that we are asking the data to be pulled, by the way, from OneCare through Medicaid and Medicare panels and claims. And we look for folks that have CHF, COPD, diabetes, maybe some contact from mental health, some contact from home health. So we look to see if there have been claims across different providers, so that we then begin to get a breadth of service providers around the table. So hope that helps others that haven't quite done that yet.
Thank you. One thing in looking at claims data, that's where we get a lot of our information from. The secondary diagnoses are almost more important than the primary, because that's usually the underlying. With our patient population, a lot of times that's not what gets overlooked. It might be addiction or pain, and we really focus in on those. So just a little tip on our end. So who's going at this table? Great.
So we're the Middlebury Health Service area. What we took from the exercise, which was wonderful, and very impressed with what Ralph was able to do and convey in his 3 different personalities, being the patient. Some of the things that we noticed, that it was really hard not just to solve the problem. Everyone just really, really wanted to solve, where you had to kind of take a step back and take a deep breath and just ask questions, get to know him, build a trusting relationship. And one of the things that we identified towards the end is understanding what motivates him, and learning more about his family was very crucial to developing that trusting relationship. And sometimes it's not about just solving what you think the solution is, but again, developing the relationship. So we've just started meeting twice a month in our small group. I guess not really small, it's like 20 people. But we've started meeting, and we started looking at different reporting tools that we have available to us. we have multiple ACOs in our health service area, so we're looking at different reporting capabilities between them and then within our primary care offices, and also what other community agencies can provide, so we can develop the list of patients that meet the criteria. And the patients that we're looking at are patients that are most at risk of having increased healthcare costs and would benefit from wraparound services. And that's the big thing. The big take-home message that we're sending across the table is it's patients that benefit from wraparound services, so we can make sure that the processes and the systems that we put in place can hopefully be successful. And so that's where we are. And we've already started coming up with challenges. Sharing information has already decided to come out, and then having a consistent message once we start talking to the patients. But all that stuff is coming down the road.
All right, who wants to go over here? If you can remind me what community you're from, too, that'd be great. Anyone? Uh-oh, not it. Not it, not it. That's what I do. I can go over here while you... Oh. Jan? I'm gonna hold off. Does someone want to volunteer over here?
This is actually very reflective of how our volunteers. I'm Julie Parker, and I am from Northwestern Counseling Services, the mental health agency in Franklin County. So these two tables are representing Franklin County. So I think that kudos to the people who did volunteer, myself included, because it is challenging to put yourself out there and do a role play in front of other people. And I think similarly to what the other table said, is I think it's really challenging to not go into a solution-focused mode and quickly tell the person what they should do when you don't fully understand the situation, and how we make assumptions when we talk to people that you must be feeling this way or you must be feeling that way, without really being clear or asking how someone feels. So I think it was a great exercise, and I feel like everybody enjoyed doing it and participating and watching and giving feedback. I think for us, maybe we're not quite as far along as other groups. So we do have a subset of people that are here today that meet every other Friday, and we call it the care coordination, care management meeting. So I think our goal is, and our project manager couldn't be here today, so our Blueprint project manager, so our goal is we meet next Friday, and our hope is that we're going to discuss more of what happened today, and then start looking at picking a subset of staff and how we want to move forward. So I think that summarizes what we did. Yeah? Did I miss anything? Anybody just jump in? They won't. Okay.
I got to see 3 out of the 4 groups, and you guys did a great job. I'm going to figure out how I can get standardized patients over to my team. But one thing that was interesting, I was talking to some of the standardized patients on the way back, and it was just as difficult for them, because they're used to people trying to diagnose a problem, and so the open-ended nature of the relationship was really, really challenging for them. So I think you guys got to learn from each other, so that was great. Well, I'm going to hand it over to Jenny to wrap up the day.
I can't coordinate holding a piece of paper and a mic at the same time, so I'm going to set it down. Okay. So first and foremost, I wanted to thank everyone who came today, because I know that you took a lot of time out of your really busy schedules, and particularly also wanted to thank the mentor communities who were here. The 3 communities that went before you, St. Johnsbury, Burlington, and Rutland, are one step ahead. They haven't said that they've solved the solution, but they wanted to make sure that I offered them up before they left, or before you left, that they really want to learn from you, and they really want you to learn from the mistakes they've already made, so that you don't have to make them. So encourage you through the facilitators and team leaders that you're working with to reach out to them. When you have questions, when you want to see what does their shared care plan look like, what have they done for different solutions, please go ahead and pose your questions. I think Laurel, as one of those mentoring communities, really posed that this is a journey. We're all really happy that you're on this journey with us together. It's going to be a lot of work. Today we only touched the tip of the iceberg, but the communities that have gone before you have talked about how valuable the work that they've done, how it makes them, has made both their relationships with each other and their therapeutic relationships feel better, and the people that they're working with, that they've have been working with for years, suddenly making progress. So it's definitely worth it. Feel free to go back and we're really asking you to test things. One of the themes that came out today is that don't let perfect be the enemy of the good. I kept hearing a couple of groups saying, but we don't have quite the data. This isn't the perfect data. Again, I challenge you to get started. Be willing to try new things, try them quickly, test them out, fail quickly, learn quickly, so that you can exponentially grow those to the next group of people that you're working with. Again, we're trying to focus here on process. So you're going to be working with individuals, but you're really going to challenge you to think about the fact that although we're going to define populations, our target really here is to address uncoordinated care and to address the processes that you're each working with. Based on that, today we learned some important techniques that can help set apart the work that we do. That we're going to try to use those techniques to move forward to engage people. And when I talk about engaging people, I talk about the people that we're working with and for and on behalf of, but I'm also talking about engaging our team members. That we're going to start by checking on our own wellness, our own test tubes, and make sure that those aren't creating and making the situation, both with our peers and with the patient and with the patients and the people that we're working with, that they're not making the situation work, and really work on our own wellness. We're going to build relationships with ourselves and with the people that we're working with based on empathy and based on caring. That we're going to foster skills among each other, and we're going to foster skills with the people that we're working with. The goal that we're leaving with is really to create authentic healing relationships and authentic teams. And that it's really that work is going to be really hard as we move forward. But we need to remember, first and foremost, to celebrate those small accomplishments and the big accomplishments along the way. So as you leave and you put in place the action plans that you're going to do and the things that you've learned today, really celebrate that you were here, celebrate that what you're going to do is to make change in your community. And on behalf of the group who planned the event, thank you for being here.